It is a great privilege to welcome you to Pre-Congress Workshop 1, the very first pre-Congress workshop held as part of the upcoming 139th Anniversary International Medical Congress organized by the Sri Lanka Medical Association in collaboration with the International Diabetes Federation, Southeast Asia region, which will take place from 22nd to 25th July 2026 at Cinnamon Life at City of Dreams, Colombo. The theme of this year's Congress, Wellness in the Nation through Local and Global Partnerships, reflects the spirit of collaboration and shared commitment that is essential for advancing health outcomes, both within Sri Lanka and across the region. Today's workshop on navigating the MASLD epidemic beyond biopsies aligns closely with this theme, emphasizing the importance of integrating local clinical expertise with global knowledge and
preparations and people are here this morning and a lot has joined online, and it's a very important topic. Of course, being an endocrinologist and in the field, it's very close to our practice, and I think the future, the next I won't say pandemic, that it's all recognized. We know the numbers, but this is a hidden patients, and sometimes over the 4 or 5 years we have missed the diagnosis, because not just because that we don't care about the liver, but just that we didn't recognize the importance of this. And you will see as you go on the lectures, the new imaging modalities and the new guidelines have helped us to discover and detect the people who are having liver issues well in advance. We have been missing the diagnosis for a long time. I have had patients who have had fatty liver in series of scans over the last 5 years, and they come suddenly with hematemesis, and then we find out that the problem was going inside and we have not detected. So I think it's for all clinicians and doctors in general, this would be a very relevant and a good workshop today. I hope you all will learn a lot and take this to your practice and improve the practice and detect patients with hidden liver problems, which will be a huge burden for the country and the health sector. But I think if we detect this early and take remedial measures, sometimes it's very simple. It's just losing 5 to 7% of your body weight that you have to do to reverse some of these problems at the early stage. It's going to be very useful, and I wish you all a very fruitful morning and academic, stimulating academic session. And again, let me thank the College of Sri Lanka College of Gastroenterologists, the Association of Gastroenterologists, for this collaboration with us today. Thank you very much. Thank you very much.
Thank you very much, sir, for those inspiring and thoughtful opening remarks. It is now my pleasure to invite the Secretary of Sri Lanka Society of Gastroenterology, Dr. Tharanga Liyanarachchi, to address the gathering.
Good morning, dear President SLMA, dear teachers, consultants, medical officers, and participants on site and online. I would like to welcome you to this symposium in collaboration with SLMA about MASLD. We have few eminent speakers to update you about MASLD today. So without taking too much of a time, I will let them to start the program now. Thank you.
Thank you, Madam. We now move on to our first scientific session. The lecture titled Beyond Biopsies, Navigating the MASLD Epidemic will be delivered by Dr. Eranga Talagala, Consultant Gastroenterologist, DGH Chilao. Kindly keep your questions ready. We will have a Q&A sessions at the end of the first two lectures. May I kindly invite Dr. Eranga Talagala to the stage.
Okay, good morning, everybody. First of all, I would like to thank Prof. Arjuna, SLSG, SLMA for giving me this valuable opportunity. Today, my task is to speak about navigating simple steatosis, then steatohepatitis, fibrosis, cirrhosis, and hepatocellular carcinoma. Right. So, okay, then comes the question of what is steatotic liver disease. So it is an umbrella term used for disease characterized by excessive lipid accumulation within the liver. So by definition, the fat deposition should be more than 5%. And most of the time, the steatotic liver diseases are diagnosed by imaging and occasionally by liver histology. So these are the disease entities comes under steatotic liver disease. So we have our topic today, the metabolic dysfunction associated steatotic liver disease. Then we have a new entity called MET-ALD, where the patients fulfill criteria for MASLD, and also they have moderate alcohol consumption. Then we have alcohol-related liver disease. Then we have specific etiology related SLDs such as drug-induced liver injury, monogenic diseases such as Wilson's disease, hemochromatosis. Then we have miscellaneous conditions such as viral hepatitis. And then we have an entity called cryptogenic SLD. The cryptogenic SLD means that we can't identify any etiological factors, at least during the initial stages. But it has been found out that significant proportion of these cryptogenic SLD patient ultimately fulfill the criteria of MASLD. So what should we do when we encounter a patient with SLD? So we have to do three things. First is we have to assess whether the patient is having cardiometabolic criteria. So what are these cardiometabolic criteria? There are 5 criteria. First one is BMI more than 25. For Asians, it is 23. Or waist circumference for males 94. For Asian males, it is 90. For females, whether it is Caucasian or non-Caucasian, it's 80. That is the first criteria. The second one is pre-diabetes, diabetes, so already on treatment for diabetes, type 2 diabetes. Third one is hypertension or already on antihypertensive drug treatment. Fourth one is high plasma triglyceride levels. The cutoff level is 150 milligrams per deciliter, or the patient is already on lipid lowering treatment. And the fifth criteria is the low plasma HDL cholesterol levels. For males, it is less than 40 milligrams per deciliter, and for females, it is less than 50 milligrams per deciliter. The second thing we have to do is we have to assess whether the patient is consuming alcohol. If yes, we have to quantify the alcohol consumption. The important values to remember would be less than 20 grams per day for women, and less than 30 grams for men, and more than 50 grams per day for female, and more than 60 grams per day for males, and the in-between group. And the thirdly, we have to assess whether the patient is having any other causes of steatosis. Right. So if someone is having steatotic liver disease, and then they are having any cardiometabolic criteria, if there are no any other causes of steatosis, then without much problem we can diagnose MASLD. If we happen to do a liver biopsy, if there is hepatocyte ballooning and if there's inflammation, then we can label them those patients as having MASH. So if the patient is having a cardiometabolic criteria, and then we have to consider for other etiologies. If those etiologies are present, we label them as having combination etiology. If there are no cardiometabolic criteria, if any other causes of steatosis present, we can label them accordingly. And if no cardiometabolic criteria, no other causes of steatosis, then we label them as having cryptogenic SLD. The same thing in a summarized manner. So according to this classification, you have to quantify the alcohol consumption. So this would give a rough idea about the alcohol quantity. So 12% wine, champagne and sparkling wine, 100 milliliters of those will contain roughly 10 grams of alcohol. In 5% beer, 250 milliliters will contain 10 grams of ethanol. And in spirits, 40%, so 30 milliliters will contain 10 grams of alcohol. So the silent burden of MASLD. So it is estimated that the worldwide prevalence of MASLD is around 30 to 38%. And we know that currently we are having more than 7 billion world population. So at least 3 billion people will be having MASLD. And there is an alarming 50% increase over the past 20 years. And the prevalence of MASLD varies by region, and the prevalence is expected to rise further to more than 40% by year 2050. And this map illustrates the prevalence of MASLD by the region. And the Middle East, North America and Latin America has the highest burden of disease. And the MASLD has become the most common chronic liver disease, and it is recently identified as a non-communicable disease. And in USA, the MASH has become the second commonest cause of liver transplant and the fastest increasing indication. So, and we know that the MASLD is tightly linked to type 2 diabetes, mellitus, and obesity. And the prevalence among the obese patient is around 75%. And the prevalence of MASLD in diabetic patient is around 69%. And by looking at this graph, you can appreciate that significant proportion of diabetes and obese patients with MASLD are having more advanced stages of disease, that is advanced fibrosis and cirrhosis. So this is a nice infographic presented in a clinical gastroenterology and hepatology journal. And out of all the type 2 diabetes patients, around 65 to 66 percent will be having MASLD, and now and 41% of type 2 diabetes patient will be having significant fibrosis, and 15% of patients will be having cirrhosis. So when you do the math, so it is more than 400 million adults with type 2 diabetes. So roughly around 40 or 50 million will be having cirrhosis just due to MASLD and diabetes. And this map illustrates the global prevalence of MASLD in overweight or obese adults. Here the highest burden of disease is found in Latin America and Eastern Europe. So what about Sri Lankan situation? So most of these data coming from our Agama group, and today our gathering is graced by those leading researchers, Prof. Arjuna, Prof. Niriella, and Prof. Anuradha. And so according to these studies, the prevalence of urban population is around 32%. In rural population, it is around 18%. And annual incidence of MASLD in Sri Lanka is around 6.2%. So this is another interesting study done by, again, Ragama Group, and in collaboration with Faculty of Business at University of Moratuwa, and this was presented in the DDW last year. And according to this, the NAFL population is projected to more than double between 2007 and 2042, and reaching around 53% of the population older than 35 years by 2042. Previously, I said that in 2050, the world prevalence would be around 41%, but in Sri Lanka, 10 years before that, we will be passing 50%. So we are facing a huge problem in the future, and already even at present, the economic impact of the disease is massive to a country like us. So it is estimated that, according to that study, the impact of the disease is around 8.8% of the GDP. When we take NAFLD alone, if we combine the NAFLD and diabetes, impact is around 1.4% of the GDP. And we all know that we are living in a country where we spend around 4 to 5% of our GDP for education. So the next part of my lecture is the MASLD, a multi-system disease. MASLD is no longer viewed as a liver-limited condition, and the modern evidence shows that it affects multiple organ systems through the shared metabolic, inflammatory, and hormonal and immunological pathways. So the MASLD can affect central nervous system, can affect cardiovascular disorders. Cardiovascular system can affect kidneys, leading to chronic kidney disease, can cause osteoporosis, and it can lead to extrahepatic malignancies. It can be associated with hormonal imbalances, could be associated with obstructive sleep apnea. And actually, when someone is diagnosed to have MASLD, his or her risk of developing new onset type 2 diabetes increased by 2.2-fold. And for fatal and non-fatal cardiovascular disease and heart failure, risk increases by 1.5-folds. For AF, the risk increasement is 1.2, for CKD 1.5, for extrahepatic cancer it is 1.5. And when we consider the cardiovascular disease and the MASLD, there is a considerable overlap of pathological drivers of both these conditions. So therefore, some even argue that MASLD and cardiovascular diseases are different manifestations of the same underlying generalized metabolic dysfunction. And when we consider the cause-specific mortality rates in MASLD, actually the cardiac-specific and extrahepatic cancer-specific mortality rates are more than that of liver-specific mortality rates, implying that the effects of MASLD extend beyond the liver. Okay, and how does this happen? So these are the key pathophysiological processes which lead to multi-system involvement. So these will be dealt in detail in later lectures. So Just to summarize, insulin resistance, chronic low-grade inflammation, atherogenic dyslipidemia, endothelial dysfunction, prothrombotic state, oxidative stress, obesity. So almost all these factors are responsible for cardiovascular disease and insulin resistance, low-grade inflammation, oxidative stress, obesity can lead to malignancies in at-risk patients. So this is how the multi-system involvement happens. And I would consider this as the most important part of my lecture. Do normal liver blood tests exclude MASLD? The screening for MASLD is challenging, and most are asymptomatic at initial stages, as Dr. Manilka mentioned correctly. And most of the time, we tend to diagnose patients later at the disease course, at that time there's only few things we can offer to alter the disease outcome. But in contrast, if we diagnose early and intervene early, it will lead to favorable outcomes compared to late diagnosis, and also economically it will be very easy to intervene at the beginning. So as Dr. Manilka mentioned, so initially it would be just weight loss would be adequate. So how to screen these patients, and the indications for screening and the screening methods will be dealt in details later. But most of the time we use our screening programs are primarily based on detecting abnormalities of liver blood test. And the aminotransferases, the ALT and ST are the most frequently used LFTs. Unfortunately, transaminases are poor exclusionary test. If they are high, it's okay, but if they are normal, we can't exclude MASLD. I will say why, and we have to think beyond the transaminases. So why I say like this is, there are good evidence to suggest that significant proportion of MASLD patients may have normal ALT levels. So the first study, it was done in China. So among the patients with MASLD, 83% had normal ALT levels, and the similar findings were arrived in the other large-scale epidemiological studies as well, such as Dallas Heart Study. Therefore, the American Diabetes Association recommends that fibrosis assessment should proceed based on the metabolic risk factors rather than LFTs alone. The second reason is the reference ranges for normal ALT varies widely across different laboratories and population, and the ALT levels depend on the age, gender, BMI, environment, and physical activity. So when we interpret ALT levels, we have to consider these things. For an example, the females tend to have lower values of ALT compared to males, and the traditional cutoff points varies from 40 to 65, but it has been suggested that those levels are too high. So the ideal cutoff levels would be in males 29 to 33. For females, it is lower. It is from 19 to 25. And the third reason is the liver enzymes fluctuate, and a single measurement may not reflect the true disease burden. And also, the individuals with MASLD may develop significant steatohepatitis and develop advanced fibrosis or cirrhosis even in the normal ranges of ALT, because we know that when there's cirrhosis or advanced fibrosis, the hepatocytes are replaced by fibrotic tissue, and also in cirrhosis, the immunological response is blunted. Therefore, anyway, because of the low hepatocyte count or the mass and blunted immune response, anyway, their ALT-AST levels going to be within the normal range. And if we go to basics, the ALT-AST, the aminotransferases, are indicators of necroinflammation of hepatocytes, not of fibrosis or portal hypertension. And in later lectures, we will learn that the degree of fibrosis is the most important prognostic factor. So by just looking at ALT-AST levels, we can't predict about fibrosis or portal hypertension. And at last, not the least, we should keep in mind that the MASLD is driven by metabolic dysfunction and not by liver blood test abnormalities. And so, the ladies and gentlemen, so the MASLD has become the commonest chronic liver disease, and the effect of MASLD extend beyond the liver. And don't exclude MASLD if LFTs are normal, especially in the presence of metabolic risk factors. And don't rely on traditional ALT cutoff. And don't wait for elevated enzymes and lose valuable time for intervention. And don't use ALT-AST alone for risk stratification. Thank you.
Thank you, sir, for that comprehensive and insightful presentation. To present a token of appreciation to the speaker, may I respectfully invite Dr. Manilka Sumanathilaga, the President of Sri Lanka Medical Association, together with Dr. Eranga Thalagala to the stage. Thank you, sir. We now proceed to our next session. The lecture title, From NAFLD to MASLD, A Paradigm Shift for Clinicians, will be delivered by Dr. Hirni Jayasena, Honorary Consultant Gastroenterologist, Senior Lecturer, Faculty of Medicine, General Sir John Kotlawala, Defense University. May I invite Dr. Hirni Jayasena to the stage?
Good morning, and thank you to the SLMA for inviting me to give this talk. So my topic is that of how the name change from NAFLD to MASLD happened, and I'll walk you through the various different changes that have happened over the last 150 years or so since fatty liver was first coined. This is an overview of my topic. So to start with, what's in the name? So we're going to go through the previous definitions of NAFLD. It was first coined in 1836 as fatty liver, and it was first seen in those patients who have had alcohol coming in with fatty degeneration, as noted by the eminent Dr. Thomas Addison. And after about 150 years later, in 1980s, the term non-alcoholic steatohepatitis was first used to describe alcohol-related steatohepatitis, but seen in those patients who had diabetes and mostly in women. This landmark study actually found it difficult to be published because a lot of places kept rejecting it, saying that it's maybe not a relevant finding, maybe it's a mistake. And in fact, after a few attempts only, he managed to get this published. And in parallel, in 1999, metabolic syndrome was first sort of found to be associated with steatosis and fibrosis. And now we are 20 or so years after that, where, sorry, the slides are not moving. Yeah, sorry, got it. There is a subgroup of cryptogenic cirrhosis where there's no typical cause for cirrhosis, but they appear to have diabetes, hypertension, high BMI, high triglycerides, and low HDL, and maybe even a family history. And this was first noticed in the 1980s. And in 2007, the term NAFLD, or non-alcoholic fatty liver disease, Thank you. Sorry about that. So non-alcoholic fatty liver disease was coined in 2007, where an accumulation of hepatic fat of more than 5% was confirmed either on radiological or histological examination without the coexisting secondary causes for steatosis. But in the last 20 years, there's been a lot of discussion about a need to change the name in order to reflect the true underlying pathophysiology. And as Dr. Thalagala mentioned, the pathophysiology is multifactorial and it has genetic predisposition, intestinal dysbiosis, disorders of lipid metabolism, altogether causing triglyceride accumulation, leading to creation of free radical formation and leading to hepatocyte apoptosis, as well as building a pro-inflammatory environment whereby which Hooper cells and stellate cells will release further pro-inflammatory cytokines, exacerbating inflammation and also developing fibrosis. And as the previous speaker mentioned, this is a spectrum of the disease. As you can see, with the beginning, it is steatosis, followed by steatosis and inflammation and ballooning, leading to fibrosis. Until that point, it is reversible, but beyond that, as later stages of fibrosis develop, the chances of heading into cirrhosis are higher. And once cirrhosis is established, hepatocellular carcinoma, decompensation, and obviously death. And certain studies have shown that even if the patient was to have a liver transplant, in the presence of metabolic risk factors, the transplanted liver can also develop further fatty accumulation, leading to the same problem once again. A very important landmark study is the study done in 2021 that looked into patients with non-alcoholic fatty liver disease, and they found that at significant standards of fibrosis, there can be liver-related events with decompensation, and ultimately death from any cause can be increased further when the patient develops cirrhosis. And this is irrespective of the underlying etiology. And it is also important to note that with those patients who were deemed as non-alcoholic fatty liver disease without cirrhosis, the cardiovascular disease still remains the leading cause of mortality, followed by malignancy. And those patients who did end up having liver transplant, as you can see from 2013 onwards, there's an exponential rise in non-alcoholic fatty liver disease among patients who had liver transplant with or without HCC. So there is a real case for needing this name change, because it doesn't necessarily include the underlying pathophysiology, which is metabolic drivers of the disease. It is a diagnosis of exclusion, and it's negatively defined by saying someone is non-alcoholic or fatty, and it doesn't help us to tease out the different presentations. And therefore, it is time, after 41 years, that we change the name. So I'd like to show you a couple of patients here, all of sort of varying presentation. And as you can see, all of them have hepatic steatosis either on imaging or on liver biopsy. But they have varying cardiometabolic risk factors. And if you were to do a biopsy on all of them, it will present with steatohepatitis. Can we all label them as under NAFLD is the question. So the new terminology of MASLD was therefore introduced in 2023 to emphasize the metabolic dysfunction as a central cause and help identify at-risk individuals with metabolic dysfunction. And it removes the stigma associated with the word alcohol and provides a positive diagnosis. So it's important to note that we are not renaming the disease, we're just redefining it. And this was done, as the previous speaker mentioned, by a large consensus having 236 panelists, including one of our senior professors from Sri Lanka, as well as endorsed by more than 70 societies and organizations to come up with this new nomenclature and definition of steatotic liver disease. And it's an umbrella term under which you have MASLD and MASLD, as well as alcohol-associated liver disease and specific SLD and cryptogenic SLD. So if we were to look through our previous patients, you will notice that the first gentleman who was obese with dyslipidemia and diabetes with minimum to no alcohol use, but having hepatic steatosis on imaging actually can be put under the category of MASLD. The lady who we met previously with dyslipidemia, hypertension, but having alcohol consumption of 5 to 6 units per week, which is actually well within the sort of recommended for daily intake for a woman, but has hepatic steatosis. The obese male with hypertension, with quite a large amount of alcohol consumption per day can actually be categorized under alcohol-related liver disease. And we have the 73-year-old lady with no previous alcohol use, with a history of AF, with hepatic steatosis on liver biopsy, with only amiodarone for the last 2 years, can actually be labeled as having drug-induced liver injury. So therefore, this allows us to be more specific and also to identify those patients who are at high risk of fibrosis and decompensation. So therefore, out with the old and try to be in with the new terms as we have demonstrated here. And just to reiterate what Dr. Thalagala said, MASLD is hepatic steatosis with one or more cardiometabolic risk factors. You have to have steatosis of the metabolic factors such as obesity, type 2 diabetes, dyslipidemia, hypertension, and insulin resistance. The alcohol use is minimum or not at all. And therefore, this is a positive diagnosis, not a diagnosis of exclusion. There have been some concern as to whether in reclassifying, have we missed out on patients who were previously called NAFLD. But in fact, studies have shown that 99.9% of overlap is present between biopsy-proven NAFLD as well as MASLD patients. Additionally, a study done in 2024, which actually used the new subclassification, found that most patients of NAFLD and MASLD fell into the same group, but there was only up to 2.8% of the national prevalence that actually categorized as MET-ALD. And those patients are the ones that we should probably focus most of our efforts into seeing how best to prevent them from heading any further into the realms of cirrhosis. So why does MET-ALD matter? It's because it has a higher risk due to combining metabolic risk of alcohol as well as metabolic risk factors associated with higher fibrosis and decompensation risk rather than in those patients with MASLD alone, supporting tighter risk stratification and research focus. And a study done in 2023 found using the new categorization that in fact fibrosis risk at 5 years was more for the MET-ALD group compared to the MASLD group. And as a summary table, I put together the following to help you differentiate between the three categories where the core driver is that of metabolic dysfunction in both MASLD and MET-ALD. And the only thing that helps to differentiate is that of the alcohol intake, which is 0 to minimum in MASLD, which could be average to moderate in MET-ALD. And of course, with the alcohol liver disease, it will be much more significant. How about its relevance to Sri Lanka? We do have high rates of diabetes and dyslipidemia, even at lower BMI thresholds. And therefore, having this framework will help us to better capture lean metabolic disease as well. Early detection means early intervention, and simplified diagnosis means better resource allocation and better patient communication and reduction in stigma. And therefore, we would have better opportunities for research. So what do we need to do when we encounter a patient with steatotic liver disease is, first of all, as the previous speaker mentioned, try to find out if there's any cardiometabolic risk factors. If there are, try and see if the patient has underlying alcohol consumption, and then depending on that, you could categorize them under metabolic dysfunction associated steatotic liver disease, or whether it could be meta-ALD. In the absence of cardiac metabolic criteria, you could see if there could be other causes for steatosis. So in summary, steatotic liver disease is the overarching term under which MASLD has replaced NAFLD to reflect metabolic causation. Met-ALD is a new entity altogether, and the diagnosis is now focusing on a positive and clinically practical setting. The disease spectrum is very important in that fibrosis, as I've demonstrated in the lecture, is a key factor in determining a prognosis of the patient. And this new framework actually allows more multidisciplinary engagement, especially between, for instance, as in today, gastroenterologists as well as endocrinologists in managing these patients. Particularly relevant in the Asian population with metabolic risk that happens at lower BMI. Thank you very much for this opportunity to speak to you, and I'm available for questions.
Thank you, Madam, for that clear and thought-provoking presentation. To present a token of appreciation to the speaker, may I invite Vidyajyoti Professor Arjuna P. De Silva, together with Dr. Hirni Jayasena, to the stage. Thank you, sir. We will now open the floor for a brief questions and answer session. Participants present at the auditorium may raise their questions directly. Our Zoom participants are kindly requested to submit their questions via the chat, and these will be conveyed to the speakers. May I invite Dr. Eranga Thalagala and Dr. Hirni Jayasena to the table to proceed with the Q&A session.
While the audience is anybody, yeah. And lots of questions, then I can't catch my colleagues there in the scope or fibroscan most of the time. So it's very interesting. And now that normal ALT is a big phenomenon. Most of the patients that I have detected recently with F3 and F4 also, the ALT has been normal. But retrospectively, we have our manual over the last 10 years. Sometimes I have records on a sort of a Excel sheet like this. We notice that the ALT has been 54, 56, below 60, 10 years back, 5 years back. And then when you look at the platelet count, 240, 210, 180, that's where it has, 160. That range, the platelet count, I would say, is a more significant sort of a positive thing. I'm just wondering, in Sri Lanka, those who have access to a lot of scans and all that, do you all have an algorithm or has somebody done an analysis of the ALTs and the platelet count, like the FIFO score, and the correlation between that, whether you can, from the platelet count, ruling out other causes, whether you can predict? Is there any sort of a study in Sri Lanka?
Actually, we don't have our data, but we can use FIFO score for risk stratification because it contains both the ALT, AST, and the platelet. So By doing that, we can actually assess the risk of fibrosis, and if needed, we can move on to the other modalities for further assessment. So if the FIB4 value is indeterminate, then we should go for a other assessment like fibroscan. Yeah. So unfortunately, for my knowledge, we don't have our values, but would be a very interesting study.
But I thought was in Sri Lankans the platelet count somewhat more
definitely, yes.
But the FIB4 is going down now. Looking back, you start thinking about the liver and analyze your patients. I tend to see that.
That's correct, because in cirrhotic patients, actually we can exclude the need of upper GI endoscopy by looking at the platelet counts at the FIB4, sorry, the fibroscan. Liver stiffness measurement. So yes, the platelet indicate portal hypertension.
Just one comment, Michael. Low platelets are a little bit too late in the disease process because the low platelet count appears when there is appearance of clinically speaking portal hypertension. So the cirrhosis has been there for some time. We don't go beyond these patients, but certainly low platelet should be a strong indicator of assessing the liver activity.
With regard to FIB4 calculation, we see the patients with more than 4 years to assess the steatosis among the patients less than 4 years. How can we?
Actually, the FIB4 score is validated for 30 and 65, so that will be dealt in later lectures. So it will be discussed.
And regarding MASLD, now usually patients with overweight patients, we used to advise with weight control and weight reduction. With regard to MASLD, how can we advise?
I think that question will be answered in the coming lectures. Don't worry. Don't worry.
When we calculate the FIB4 score, we have to give this for finance in the domestic pain.
Again, we will be talking through all of that, so don't worry.
I would like to know whether there is a predisposition in the South Asian region for the MASLD, or is there a higher prevalence?
Because we are having diabetes and obesity, central obesity. So of course we have very high rates in South Asia. So it's around 30 to 32% in the South Asian region.
That is
genetic predisposition. Yes.
So, we were interested in sleep. I have patients come with sleep apnea. Incidentally, I see a lot of fatty liver, even in the patients of fatty liver scans. When there are obviously other investigations in that are sleep apnea. So, where the hypoxic burden, the nocturnal hypoxic burden is one of the drivers of inflammation. And there is a spectrum of the metabolic diseases associated with it. So I wonder whether all MASLD patients should be screened.
Yeah, actually, it is an. So it is an the obstructive sleep apnea is an indication for screen for MASLD. It's a well-known indication.
That means a lean, say like a BMI of 24 with sleep apnea. They tend to detect people in Sri Lanka with low BMI sleep apnea.
Yeah, again, it is an indication for a screen for MASLD.
Just one community, nice examples we are taking now to illustrate the various categories of steatotic liver disease. Unfortunately, you used units in your examples, and in true spirit of out with the old and in with the new, we talk of grams because units are varying across various regions. If you take the US, the UK, Asia, units are confusing. WHO has actually totally given up using units to quantify alcohol. Please use grams. It's not very difficult. What you need is the volume of alcohol, and the type of alcohol will have the alcohol by volume. You multiply that, and you have to do a correction by 0.8 because the alcohol density is less than water density. So it's the volume of alcohol. If it's beer, whatever volume, yeah. So those were good examples to just to remember to convert the amount of alcohol. But if you really want to calculate in your patient, it's volume, alcohol by the grams, and then the correction 0.8. So use grams always because the new guidelines definitions all go by grams per day.
And of course, quick one, the metabolic risk factors. If you look at, you think about this audience, I think all of us should, I definitely need to get myself screened because it's most of the Sri Lankans, 90% will have to get screened. If you look at the metabolic risk factors there, the lipid levels and all that, no? So I think we are all almost 90% at risk in Sri Lanka. Any other question? This one.
Thank you very much for the interesting lectures. So I have one concern that so there will be some patients that will have been diagnosed later with the advanced cirrhosis or advanced fibrosis conditions. But with those patients, it is obvious that we cannot find steatosis, basically with the autotonically or even with biopsies. So still that those patients can be classified under the broad term of MASLD. So at which place we have those patients?
So then I think I will have to look back retrospectively. So the patient is having a cirrhosis, so advanced fibrosis. Then we have to assess the risk factors. So if he's having metabolic risk factors without harmful consumption of alcohol, then we can assume that this must be MASH cirrhosis. Would you like that?
As long as we have ruled out any other positive agents like viral hepatitis C,
Wilson's disease,
depending on the age, sort of things like hemochromatosis and ANA for autoimmune hepatitis. I think then we could safely say, given the metabolic risk factors, that it most likely is MASH that has resulted in this.
Another concern is that with regard to the cryptogenic steatotic liver disease, so do we have any specific set of investigations to rule out that cryptogenic, because we have a lot of things to concern, including the cerebroplasmin, ferritin, and all these things. So do we need? Do we have?
Ideally, depending on the age, when we confront the patient with cirrhosis, ideally we should evaluate for all the etiological factors, especially if it is less than 55 alive. So then, if we can't find any etiological factor, then we label them as cryptogenic cirrhosis.
Thank you very much.
I think we'll proceed. Did you check the online? Okay. Okay. So, did you check the online? Okay.
Thank you, sir and madam, and thank you everyone for your active participation. We will now take a short break for refreshments. Refreshments is served outside the auditorium for those present here. For our Zoom participants, we will resume shortly, and we encourage you to stay connected. Before we break, I would also like to mention that for those present here who are interested in becoming members of the Sri Lanka Medical Association, membership application forms are available at the registration desk. We warmly encourage all eligible participants to take this opportunity to join the SLMA and be part of the prestigious professional community. We will resume promptly at 10:30 a.m.
Good morning, everybody. First of all, let me thank Professor Arjuna and SLMA and everybody to inviting me to speak a few words about this topic. So I've been asked to talk about identifying MASLD in everyday practice. So these were the objectives that were given to me. So I'm trying to stick directly to the objectives because otherwise we might be overlapping, because you might have noticed a trend of overlapping in these topics. So who to screen, interpreting liver function tests, and we might be coming across some of the questions that was asked in the last session, limitations and pitfalls of liver function tests, non-invasive scores, including the FIB4, and the primary care algorithms that we might be able to use. A mango analogy, if you might allow me. Yeah, something with the my screen. Okay, my screen is gone, but yeah. So asking to it's like a little bit like going to an orchard full of mangoes, stepping on mangoes, and walking up to the garden and saying, "My good man, I wonder whether you could help me to identify something called a mango." So he would give you the answer. Of course, just open your eyes. It is all around us. So actually, that's my summary slide for MASLD also identifying. It is just all around us, everywhere. So that is really my lecture in a nutshell. I think they're getting my screen back. If you give me a second. Yeah, okay. I think I will have to look at this. Yeah, so yeah, my computer is not working, but we'll start. So next question is fine. Screening for MASLD. What do we want to screen for? Well, we can screen, of course, for MASLD, and you would have heard 2 excellent lectures describing what it is. But internationally, the guidelines, actually, the American, APASL, everybody, what they focus is on the second category, MASLD with fibrosis. So what they say is screening for MASLD is fine, but identifying patients with fibrosis is emphasized because that is what is considered to drive the liver-related outcomes. The presence of steatosis is not independently associated with liver-related outcomes per se, and the stage of fibrosis, persistently high liver functions, etc., will associate with these outcomes. Yeah, I think there's a... Sorry. So when we screen patients for MASLD, it's fine to say, I saw 100 patients who had fatty liver disease, but if we can further pinpoint, I saw so many patients who have at high risk of fibrosis, that would be slightly more beneficial. Next question, who do we screen? So you would have heard of all the percentages in our population. So let's say we screen everyone. So to get a disease where you have a pickup rate for about 30% or more than that sounds reasonable, but what the guideline says, screening for liver steatosis amongst the general population is currently not recommended. There is no evidence to support fibrosis, and there is no RCT that it shows changes outcomes. So basically, the guidelines don't recommend just screening everybody, but what they say is a pragmatic approach. It's called a targeted case finding of high-risk groups is recommended. So that is what we should do in our screening and our clinical practice, targeting case finding high-risk groups, especially targeting the increased risk of getting liver fibrosis. So this is the ESA 2024 guideline with a few societies. So this is actually the summary here. Because who to screen is a slightly controversial point, but this is the main categories for you to see what's happening. we're going from the strong recommendations to the weak recommendations. So screening for MASLD with liver fibrosis is strongly recommended in all type 2 diabetic patients. And I'm fortunate to speak to a group of endocrinologists and to discuss this. Also, abdominal obesity is strongly recommended, especially with one or more metabolic risk factors. Then, of course, as discussed, abnormal liver function tests strongly recommended. And there are groups which are recommended with slightly weak recommendations. If you have metabolic risk factors, that is a group. And of course, if you find radiological evidence of hepatic steatosis. So why diabetes is so important? So the presence of and the duration of type 2 diabetes is a major determinant of liver fibrosis and the risk of cirrhosis as well as hepatocellular carcinoma development. So here the duration is also a very important key factor, as been illustrated by the Ragam health study and so many good evidence. So if you have two patients, a newly diagnosed diabetes, it's good to screen that patient, but you might have another patient who says, who had diabetes for 10 years, and he would probably be important because he would probably say, no, I had a scan done, I have no fatty liver disease. When was the scan done? 8 years ago. So that duration is what is key, because the more the duration, the more the risk factors duration, there's increased likelihood of fibrosis and long-term outcomes. Of course, the next strongly recommended one is obesity, particularly high BMI or abdominal obesity with one metabolic risk factor. Next group is metabolic risk factors. So I think Malika explained that that everybody will be having, even this audience. So if you look at it, you can see why everybody has fatty liver, why every scan has fatty liver. That's because obesity in our population is if you have a BMI more than 23, central obesity, waist circumference more than 94, females more than 80, impaired glucose tolerance. Is someone's fasting blood sugar more than 100, PPBS more than 140, HbA1c more than 5.7, blood pressure more than 130 by 85, triglycerides more than 150, dyslipidemia and HDL less than 50. Are they on statins? So that's why we are surrounded by mangoes. I mean, metabolic associated fatty liver. And of course, incrementally, the more risk factors you have, the greater your risk will be. Of course, we have to go behind people who have high liver functions, but even mildly elevated liver functions in patients who have metabolic risk factors will be significant. And of course, if they have imaging, CT, MRI, incidentally found to have steatosis. Sorry. So there are other groups that we may consider screening and might be helpful. One is first-degree relatives of individuals who have advanced liver disease. Now, the ESL guideline doesn't make a strong recommendation in this group. However, the American one does touch on this topic. But the fact is that they are at a higher risk of MASLD and higher risk of advanced liver fibrosis, or up to 12% independent sometimes of metabolic risk factors. So now in this picture, you can see this is one of my patients from Kalutara on the left, who has popped in to see us at the casualty medical ward, Kalubovila. So he has decompensated cirrhosis on the left, and we have to remove his ascites with this thick layer of fat on his abdomen. But what is also concerning is his two children on the right side. So you can see both have central obesity, strong family history. So he is not a candidate for liver transplant. He is just past 60. However, they are in their 30s. If they develop cirrhosis in their 50s, then they may be candidates. So it's not just looking at the patient, but it's also looking at the family. They are at increased risk, and that would be a good opportunity screening if you have an opportunity. Also, other groups that we discussed, males over 50, postmenopausal women. These are associations, and I think already we discussed the importance of obstructive sleep apnea and even polycystic ovarian syndrome. So there aren't guidelines to, I think, directly say all patients who have obstructive sleep apnea have to have this screening, but definitely as clinicians, these are things we should think about to try to catch them early with early fibrosis. So this is actually a comparison of the different society guidelines. This is not directly MASLD, it is screening for liver fibrosis. And I won't apologize for the busy slide because this is how cut and paste unfortunately works. But all the people who have binoculars or telescopes can see at the bottom that the societies change slightly. Like everybody agrees diabetes, you have to screen. Everybody agrees obesity, but how many metabolic risk factors are significant? How should we use screening? These are things that are open to discussion. But interestingly, you can see they all agree that the screening test is probably best as the initial one, as the FIB4 score. It has its limitations, but that is what is recommended. So next is, do we have real world data? Now, these are things we think are reasonable. These are expert opinion guidelines, yes. So now we do have real world data. This is a study which came just last month. So it's from an Asian cohort, so it's more significant to us from South Korea. All the values cutoffs used are for Asian, the BMI 23, etc. So what they have found is, if you have 2 or more cardiometabolic risk factors, they achieve the highest sensitivity, that's 86%. However, the specificity was modest, about 50. So if you increase the number of risk factors, then you have less sensitivity, but you are obviously more specific. So basically what they recommend is this group, if you have diabetes or obesity or 2 or more cardiovascular risk factors, they say that there is a sensitivity of 81% for screening and a moderate specificity. And another question is asked about lean MASLD, so that's addressed. So lean MASLD is commoner in the Asian population, and that may be why it's not talked so much specific guidelines. So here, 2025, the APASL guideline defines lean MASLD as BMI less than 23, not 25, with hepatic steatosis, with at least 2 or more metabolic risk factors. And in this group actually it's recommended proactive screening because they may have a worse outcome. So it's something significant. Okay, so now we are going to screen. What are we going to screen with? Liver function test, scan, or FIB4 score. So all can be used. However, what is really recommended is the FIB4 score, because we've discussed in the discussion the plus and negatives of using liver function tests. And the scans also, it may give you fatty liver, but it is very operator dependent, and it doesn't really give us a grading of liver fibrosis. So FIB4 is endorsed by all societies, as you saw. So a quick word, let's say you found a patient with fatty liver, what are the liver function tests you would consider doing? Now, mind you, this is a condition where 30% or more of a population can turn up at our doorstep with high liver function. So what are we going to do? So definitely SGOT, SGPT, we do the liver profile or fluorescence. Remember, so it's associated with more inflammation, as Eranga very nicely explained. So if the SGOT is more than the PT, that suggests that the liver fibrosis has started. So we should be looking at not just the values, but which one is the higher one. Also, we can have a gamma GT elevation, because we're talking about MASLD. So gamma GT is commonly elevated, but the alkaline phosphatase is typically not elevated. But these are all modest elevations. We're not saying like extremely high elevations. And I would always ask when somebody says, I have a patient who has fatty liver, can I send to you? I would always, and they say, wait, I'll get the liver profile done and send. But I would always say, please do the full blood count and send, because as we discussed, it's the platelet count which shows whether we are going towards liver fibrosis or not. And it is the platelet count. We need to calculate a FIB4 score. So once you have a patient with fatty liver, we have to screen for metabolic risk factors, because let's say the patient has steatosis, they may be having underlying impaired glucose, they may be having dyslipidemia. So we have to strongly screen for those. So we are looking for other causes, hepatitis B and Wilson's, all those things are important. But in an obese patient, if he doesn't have diabetes, screening for underlying impaired glucose tolerance may yield a greater benefit for that patient than diagnosing Wilson's, say, in a 50-year-old patient. So usually we would do hepatitis B surface antigen, hepatitis C virus antibodies, and ANA. So I won't go into the detail of all the different tests to do, but it is complicated, and things like iron studies are altered in patients who are MASLD and MASLD as well. So therefore, these are generally accepted in a large population. So what are the limitations and pitfalls of liver function tests? So elevated liver function tests are associated with increased liver-related mortality. We know that. And also lower thresholds are proposed. So you can understand how controversial this is, that my lower thresholds are different to Eranga's slides and his lower thresholds. So you can see different societies. These are all things which are up for discussion. However, what we need to know is that normal AST, ALT levels can still have significant steatohepatitis. They still can develop advanced fibrosis. So no, just because a patient has normal AST, SGPT, SGOT doesn't guarantee that they are safe. So what is recommended is the FIB-4 score. So this uses blood-based tests and age. And usually what we use is a cutoff less than 1.3 is used. This is used to rule out fibrosis. To say less than 1.3 makes fibrosis unlikely. Alternative, if it's very high, of course, we can say it is very suggestive of fibrosis. But therefore, we have this intermediate range, 1.3 to 2.63, where we need a second modality. And that is where we would probably either aggressively treat the risk factors, or we would go for a second modality, which would be elastography. And I'm sure you'll be hearing a lot about that as the day progresses. However, this is an imperfect test, as many things are. There are limitations of FIB-4. So so you can see we are using the age. So if we are multiplying by the age, obviously elderly patients will get a higher level. Younger patients will get by default a lower level, irrespective of that. So it's skewed. So in old individuals who are older than 65, they say that the cutoff should be raised to 2. This itself is slightly controversial because ESL and the American guideline agrees, but Asia Pacific people who might not always agree with things in the West. So say, let's not do that. Let's catch more people who have fibrosis. So similarly, despite good negative predictive value, they can still miss about 10% of patients with advanced fibrosis. And also, there are some studies which show that there's limitation in patients with diabetes, that they might not be so good at catching liver fibrosis because some diabetic patients may have normal AST, ALT levels. And one study shows about 11% false negative rate in diabetic patients. But we don't have very good alternatives. Now, these are other things that you can do, NAFL fibrosis score. So now we're using more markers, more complicated calculations. So age, BMI, hyperglycemia, platelet count, albumin. However, there is one study here which showed that using it in primary care setting for screening of MASLD fibrosis was not cost effective. And of course, there are lots of tests, as you can see. So this is the ELF. It uses metabolites in part of fibrosis, like hyaluronic acid. But again, in our setting, doing a FIB-4 is sometimes difficult. That's what is more reasonable. So these are not things that we can really practically achieve in patients who have come in maybe up to 30% of our population. So what are the algorithms that can be discussed? So usually this is from the ESL, but the American one is also similar. A multi-step approach is recommended for case detection. So the first one we should be thinking according to these. It's a FIB-4 score, despite all its limitations. And therefore, after that, if it is significant, we can go forward. So here we do the FIB-4. If it's less than 1.3, they recommend that we can do it 1 to 3 years, repeat the FIB-4, but you can see that 1 to 3 is a big margin. So the American one uses 2 to 3 years. So basically, if we are worried about patients, we should repeat it at a closer interval. That's the basic summary that I have to say. If it's very high, of course, you refer to the further investigation. And if it's in this intermediate range, 1.3 to 2.67, there is an option of whether we are aggressively getting them to lose weight or whether we are directly going to elastography with our limited resources, but both are reasonable options. But as we just mentioned, if a patient is less than 35, these values can be less reliable. And there is some argument that maybe we should have to bring down the margin if we're using in younger patients. So these are my take-home message in response for objectives. Screening with targeted case finding in high-risk groups is recommended, not just to diagnose steatosis, but to identify those with fibrosis, which actually drives liver-related outcome. Screening with diabetes, obesity, and especially abdominal obesity and metabolic risk factors is recommended, as well as those with high liver functions and steatosis diagnosed on imaging. Elevated transaminases is associated with inflammation and mortality, but normal liver functions do not exclude MASH or fibrosis, and a FIB4 score is recommended. And if elevated, it needs further investigation, although it has limitations. But I'd like to point out that as part of each of these steps, what is important is to facilitate weight loss at each step, not just each time we should be getting them to lose weight. Sometimes I get from diabetic patients who have a huge body weight, and they're wondering why the liver functions aren't coming down. So they have to lose weight. For example, I just put this patient on the top right is actually one of my patients in a Middle Eastern country. So that's why he's wearing his T-shirt from McDonald's with their logo. I'm loving it, and he's loving it because this is one day before he's going for bariatric surgery at Kalubowila, and you can see this is the conundrum where we have to do the screening, but reducing weight is the key at each stage. Thank you very much. Thank you very much.
Thank you, sir, for that informative presentation. To present a token of appreciation to the speaker, may I invite Dr. Manaka Sumanathilaga, the President of the Sri Lanka Medical Association, together with Dr. Manjula Senanayaka to the stage. Thank you, sir. We now move on to the next lecture. The session titled Beyond Biopsies, Modern Approaches to Liver Assessment will be delivered by Professor Madhuni Niriyala, Professor in Gastroenterology, Faculty of Medicine, University of California. May I invite Professor Madhuni Niriyala to the stage?
Good morning. I'd like to thank Prof. Arjuna for the kind invitation and Manika for choosing MASLD as the first pre-congress topic, because it's so common and we should be talking about it. My topic is Beyond Biopsies, Modern Approach to Chronic Liver Disease. I have no relevant conflicts of interest to declare regarding this topic. So in the next 20 minutes, I'd like to talk about why is liver fibrosis important in our clinical practice when we talk about MASLD. What are the non-invasive tests for assessing liver fibrosis? What is the new standard? And we'll talk about some of the non-invasive tests and the optimal way to use non-invasive tests in clinical practice, a stepwise approach, which also will be covered by Vidita, I think. So I'll just touch upon it. And thank you, Maranjana, for covering most of these topics. Why is liver fibrosis so important in our clinical practice? So fibrosis predicts mortality. If you have liver fibrosis, it not only predicts your liver-related outcomes, it also is a marker of overall mortality. So liver fibrosis is very important. When we talk about liver fibrosis, what we are talking about is significant liver fibrosis, which is F2, F3, or F4. I'll tell you what F2, F3, F4 means. So this is important regardless of the etiology of the liver disease, whether it be MASLD or alcohol or viral hepatitis or autoimmune hepatitis. So fibrosis is key, and assessing fibrosis is very important in assessing our patients with chronic liver disease. So liver fibrosis should be assessed in all individuals with chronic liver disease. This is most important predictor of the clinical decompensation, future risk of cirrhosis, hepatocellular carcinoma, and liver death. It also prognosticates and helps us to stratify our treatment and the surveillance strategies and to evaluate response to treatment, whether it be any weight loss, abstinence of alcohol or whatever. And it's also a key surrogate marker for endpoints in clinical trials. And there is a great need for rapid assessment of this liver fibrosis. We can't do biopsies in all of our patients because our patients with MASLD population is so big. So we need we need to select patients who will need liver-directed therapies, who need screening for varices and malignancy, and those who are eligible for clinical trials. So we need better ways of assessing fibrosis other than liver biopsy. If you do some math and see how much of a problem is MASLD in Sri Lankan population, we have about 22 million population, 14 million adult population. We know from our epidemiological studies that about 33% of patients will have NAFLD. This is 2014 data. This is going to be more in the present context. But if we even apply this 33%, about 4.5 million people with MASLD. And out of that, about 25% will have steatohepatitis, the most severe form of the disease, at 1.1 million. And out of those NASH patients, about 5% will have cirrhosis already. So that's about 55,000 patients with cirrhosis. So 55,000 cirrhosis, and in between we have significant fibrosis, which would be around 250 to 300,000 patients. So huge population of patients with significant fibrosis in the community that need assessment and identification. So the liver biopsy was thought to be the gold standard, but it is not. What is an ideal marker for liver fibrosis? The optimal method of evaluating liver fibrosis, it should be accurate, it should be precise in its measurement, it should be dynamic, it should be responsive to the changes in fibrosis level over time, it should be cost effective so that it should be low cost, and we should be able to mass use whatever the test that we are using. It should be accessible, available at point of care in our clinics, and it should be acceptable to the patient also. And it should be reproducible. We must be able to repeat it many times, and biopsy does not meet most of these criteria. So although the liver biopsy was the gold standard, now it is going out of favor due to various limitations. We are only sampling 150,000 of the liver when we are doing a biopsy, and we are missing a whole lot of liver. And it is costly, about 200,000 rupees in the private sector. And there are adverse events, not just pain, bleeding, and even death. And there is reluctance on the part of the physician as well as the patient to undergo the liver biopsy and subject our patients to liver biopsy. So a lot of problems. And it has practical issues. There is a lot of variance between the observers, the pathologists, and in between patients and the same patients. And we have a lot of technical difficulties also in doing liver biopsy in obese patients. So then we have this new standard, which is replacing the liver biopsy, which is the non-invasive test of assessing liver fibrosis. So it offers an alternative ways to determine the degree of liver fibrosis, which is reproducible, widely available, and at a relatively lower cost than a biopsy. So monitoring becomes safe and simple way to support the diagnosis over time because it can be repeated. It is cost effective, much cheaper than the liver biopsy. And it can assess varying degrees of liver fibrosis, but mostly the presence and absence. And it is increased identification of the advanced fibrosis. We want to catch the patient not with mild fibrosis, but with significant and advanced fibrosis. And we are able to do this with the NITs. So NITs have overcome many limitations of the liver biopsy. They are repeatable, easy to interpret, enable monitoring over time, and the liver complications over time. So now we are doing less and less liver biopsies because we have actually eroded the value of the liver biopsy and raised the threshold of doing a liver biopsy only when we can't get the information that we need from the non-invasive test, only that we will resort to a liver biopsy. So we are doing less and less liver biopsies. So these are in NITs, what we are trying to identify and stratify is the degree of hepatic fibrosis. This comes from viral hepatitis C studies, histological studies, where we refer it to as the METAVIR score. We have F0, no fibrosis, F1, portal fibrosis, which is mild fibrosis, F2 is septal fibrosis, moderate, F3 is numeral septal fibrosis, but no cirrhosis, that is severe fibrosis, and F4 is cirrhosis. So what is meant by clinically significant fibrosis is F2 or more. Advanced fibrosis is F3 and F4. So we must remember these terms. So what are the non-invasive tests that are available to us? We have simple scores and proprietary serum tests, which are broadly blood-based. So we refer to them as wet tests. The most widely used simple score is the FIPO. I'll talk about that. Mananjan has already talked a little bit about that. The proprietary serum tests are not available to us, even if we can send the blood overseas to get these done, like the ELF. It's very expensive, not practically available. So then we have the image-based techniques, which are referred to as dry tests. What we have usually in our clinical practice is the elastography, which is the vibration controlled elastography, VCT or fibroscan, as we commonly refer to. And then we have other ultrasound modalities, shear wave elastography, which is 2D or point shear wave. And MRE is the best, but we don't have it in clinical practice. So what makes a good NIT? So NIT must be sensitive and specific to determine the presence or absence of advanced fibrosis. So usually when we refer to a test in medicine, we refer to a cutoff and we say it's elevated, and beyond the elevation, we say it's mild, moderate, and severe. Now here it's little different. When we are using NITs, we have two cutoffs. That is to increase the sensitivity and specificity of the test. We have a lower level cutoff where we maximize the sensitivity. We want to catch many patients with advanced fibrosis as possible. So that's a lower cutoff. The lower cutoff is for ruling out advanced fibrosis. Then we have an upper cutoff, which we maximize the specificity. We really want to identify those with advanced fibrosis, and we don't want to wrongly diagnose these patients. So these NITs, every NIT has a upper cutoff and a lower cutoff. The lower cutoff is to rule out advanced fibrosis, and we have lower cutoff to rule out, upper cutoff to rule in. And then we have an in-between group, which is indeterminate, which will need an additional test to subclassify. So the indirect, the simple blood-based tests are usually based on serology, the platelets, AST, ALT, and various clinical factors like the age. These can't accurately define where the patient is exactly with regards to F2, F3, F4, but they are very good at excluding advanced fibrosis, and that is what we want at the community level, at point of care. So the simple tests, the first-line tests, are good at excluding advanced fibrosis. So the most commonly used is PIB4. It uses age, AST, ALT, and the platelet count. The NSF has 3 additional: BMI, albumin, and the diabetic status. So NSF, as Mananjana very well said, is not cost effective. So we tend to like the FIB4 because most of our patients will have the data to calculate the FIB4. The serum tests are more complex. They are not widely available. They are also good at excluding advanced fibrosis. The dry tests are the image-based tests. They use elastography or the liver stiffness to assess the degree of liver fibrosis. VCT is what we have. 2D shear wave elastography and point shear wave elastography is available, but is not very well validated as the FibroScan. MR elastography is not available to us, but that is the best. If we talk about elastography a little bit more, FibroScan, accurate in detecting advanced fibrosis, predicts decompensation and complication. It very well correlates also with not only the degree of fibrosis, but also the portal hypertension. Again, it's helpful in ruling out advanced disease, and it is the most widely used. MR elastography, although not available, is the best, but it is very costly. And it is not certainly point of care. So elastography measures the liver stiffness, which correlates with the degree of fibrosis. So it measures the stiffness over an area, which is about 100 times that of the liver biopsy. So we are getting more liver tissue analyzed, so better reading. Sometimes we have problems with obesity, but then again, we have special probes to overcome that. When we are doing FibroScan, we must remember these patients should not be undergoing FibroScan if they have an active hepatitis. For example, after recovering from a viral hepatitis, dengue or whatever, give some time for the liver to recover. If they are taking alcohol, 2 weeks abstinence. If they have heart failure, liver congestion, you should treat the liver congestion first, and always make sure that there is no liver tumor on the right side that can make these measurements inaccurate. MRE, I don't talk about MRE. So what are the limitations of these tests? No test is perfect. If we take failure rate, if you can see, the simple tests have negligible failure rate because they are based on definite values. But the technical dry tests, the image-based tests, have varying degrees of failure rates, and the most common confounder is obesity. If we compare the accuracy and accessibility of NITs for the assessment of liver fibrosis, the more complex the test, more accurate it is. So the MRE is the most accurate. But the downside is it's inaccessible, it's not point of care, it's not available, and it's very costly. Whereas the simple blood test like the FIB4 is easily available, low cost, but the accuracy is less. So what is the optimum way to use? I'll quickly go through this because Udit also might talk about this. So NITs are valuable for excluding advanced fibrosis or cirrhosis. They are not sufficiently predictive when used in isolation, so we have to use them sequentially. So combining one serum test, a wet test, with one dry test like elastography can be used as first screening with the FIB4, then confirmation with a FibroScan. And this algorithm is at a level. So this is what we do by combining one NIT to another. So by applying the first NIT, like the FIB4, we have a large indeterminate group. And this indeterminate group, if we apply a second NIT, like the FibroScan, classify the patients again by applying a second test. So in the primary care, where there is a lot of patients to be screened, the likelihood of having advanced fibrosis is less. What we want is a simple test like the FIB4. So at primary care level, GP level, or anyone who is not dealing with liver disease, like the endocrinologist or the cardiologist, anyone who comes across patients with cardiometabolic risk factors, the screening test would be a FIB4 initially. But when it comes to specialized care with regards to liver disease, we need better tests. And then we need, because the likelihood of having fibrosis is higher in the tertiary care and secondary care, so we need better tests. So in the hepatology setup, we use FibroScan. So this is the step-wise assessment, which I think Udita will go through. Just make sure that FIB4 is age dependent. So you can apply FIB4 for patients in between 35 and 65. That is the age group where FIB4 is validated. You can't apply it to patients who are less than 35. There is no way, because in a 14-year-old with steatosis, even a FIB4 of 1 may be significant, a younger child. So we have to go for FibroScan for the younger patients. For the older patients, I think someone already mentioned, we use higher cutoffs. 1.3 becomes 2.0. So this, remember some of these values. For the standard age group, 35 and 65, it's 1.3 that rules out liver advanced fibrosis. And it is 2.67 that rules in advanced fibrosis. So if we are indeterminate in between 1.3 and 2.67, we have to apply the second test, which is FibroScan. Again, FibroScan less than 8 excludes significant liver fibrosis. More than 12 rules in and needs a liver sort of hepatology referral. So FIB4 has been around for a long time, but unfortunately FIB4 is going out of favor, especially in diabetics. Mananjana very correctly quoted a very important study that, up to about 10 to 15% of patients can be miscalculated based on the FIB4. So some of the guidelines are now not recommending that we go straight for FibroScan. That is in resource, not in resource limited settings, but in our setting, probably we'll have to stick to the two-step. There are better non-invasive tests like the metabolic dysfunction associated fibrosis 5 score, or the MAF5, which takes into some simple parameters: diabetes, waist circumference, BMI, AST, and the platelets. So that apparently is better at detecting advanced fibrosis, the pre-cirrhotic patients, than the FIB4. And there is another score like the SAFE score, the steatosis associated fibrosis estimator score, which takes into additional parameters like the AST, ALT, both globulin and the platelets. But unfortunately, in our practical setting, we might not have all these data to calculate SAFE score. So probably in the future, we will see more of this MAF5 than the FIB4 in some other guidelines, because FIB4 is not optimal. Then there are other ways of looking at your patients by increasing the sensitivity and specificity by combining your blood-based test with a imaging. So if, for example, we have something called the FAST score, which combines the liver stiffness measurement, the CAP measurement, which is the fat content in the liver, and AST. And similar, if you have MRE at your disposal, we can calculate what is the MASLD score, which is the best score that outperforms all of the scores, but is based on the MRI stiffness as well as the AST. So in conclusion, due to a high burden of liver disease and the risk of discomfort of liver biopsy, accurate and reliable assessment of liver fibrosis, the biopsy is going out of favor. The fibrosis stage is used to prioritize patients with regards to our treatments, and it also predicts outcomes. So assessing the stage of fibrosis is very important. Non-invasive tests include both serum and imaging tests. Both the non-invasive tests have advantages of being more accessible and avoiding complications of the traditional liver biopsy. The greatest value of the current N90 is the negative predictive value. We are excluding patients with advanced fibrosis. So they have better sensitivity than specificity. So these are more useful at excluding our patients who have advanced fibrosis. So sequential algorithm, two-step assessment, first with a FIB4 and then with a FibroScan is the current recommendation. So in the primary care setting, if you have your patients, apply the FIB4 and then refer for FibroScan if indicated, and then for hepatology referral. Thank you.
Thank you, sir, for that enlightening presentation. To present a token of appreciation to the speaker, may I invite Vidya Jyoti Professor Arjuna P. De Silva to the stage along with Professor Madhuni Niriyala. Thank you, sir. We now proceed to the next session. The lecture titled Selecting Patients for Fibroscan, Clinical Pathways and Priorities will be delivered by Dr. Udita Dasanayaka, Honorary Consultant Gastroenterologist, Senior Lecturer, Faculty of Medicine, University of California. May I kindly invite Dr. Udita Dasanayaka to the stage.
Good morning, and first of all, thank you. Special thanks to Professor Arjuna De Silva and Dr. Maniklas Mandiraka and the SLMA for inviting me for this lecture. I was prepared for a concise and short lecture, and due to the excellent comprehensive lectures before me, I have watched my lecture getting progressively shorter and shorter. Let's just see if I can sort of navigate through the slides without avoiding repetition and boring you too much. So basically, I'm just going to talk about selecting patients for FibroScan and for further assessment, and about the current recommendations in clinical pathways and priorities. So I'm just going to go through, of course, all of this has been dealt with in previous lectures, but some practical aspects of selecting patients, the spectrum of NITs available to us and how we use it, and why clinical care pathway is important, and just mentioned about new developments. So this has been topic has been dealt with extensively in the previous lectures. So, but first, when you're using a test, when you're using any sort of test to identify people at risk of developing cirrhosis, it's always good to have a high pre-test probability. As in, you have to narrow down the population so that the test will be able to perform better. So then you will have a best outcome when using these NIT tests. So that's why it's important for us to identify who is at risk of progressive disease, of advanced fibrosis, of cirrhosis, out of all the patients with MASLD. So as we mentioned, these patients type 2 diabetes, obesity, males with fatty liver over 50 years, postmenopausal women, and multiple metabolic risk factors, persistent elevated liver enzymes. So these are all sort of flags for you to identify these patients and integrate them into the clinical care pathway. Again, if you take a patient with type 2 diabetes, the prevalence of advanced fibrosis could be anywhere between 6 to 19%. And if you have someone with medically complicated obesity, then again, the likelihood of having fatty liver with fibrosis is quite high, even up to 30%. And another thing I wanted to highlight was that a patient with a first-degree relative of a patient with cirrhosis due to NAFLD and NASH, or MASLD and MASH, as we now prefer to call them, is actually at a high risk of developing advanced fibrosis themselves. So that's why I think Dr. Mananjala had this excellent graphic representation, that photograph of the patient and the children. Those children, as he mentioned, are at very high risk. So those patients should be integrated into the clinical care pathways quite early. And importantly, with each additional metabolic syndrome trait, then the liver-related outcomes, the risk of fibrosis, cirrhosis, decompensation, everything increases. So patients with multiple metabolic risk factors, yes, definitely you have to screen them with priority. And F, as Professor Nirial comprehensively dealt with this topic earlier, I'm just going to just show this this picture just to remind you that we have simple tests, but we have expensive and more accurate tests. So especially when it comes to patented biomarkers, or if it comes to tests like FibroScan and MRE, progressively your cost of investigation increases. So if you are to use, if you are planning to use expensive investigation, more accurate investigation, it is always again good to use that in a patient who has a higher risk of having advanced fibrosis. So then that investigation will be more effective. So that's why we try to narrow down patients as much as possible before we go ahead with an advanced non-invasive test, an NIT. So for example, if you want to do a MRE, in a patient, it's extreme. Even in India, there are only 2 or 3 places that have the MRE facilities. It's not about the machine, it's about the software. It's, I would say, prohibitively expensive. So that's why practically that is not available to us. So I think the best NIT we have are image-based NITs like the FibroScan. I mean, because things like ultrasound-based elastography are not properly, I mean, it's not as validated as FibroScan. So FibroScan would be the best NIT available to us at present. So again, we have, as Eranga mentioned in the first lecture, we have a very high burden of MASLD in the community. So we have to always think about practicality and cost effectiveness. So use the simplest and cheapest test first, and then when you use expensive tests, make sure that that test is able to perform good, well in that patient, because that patient has been selected for that test. And of course, limited availability of specialized testing. I think this question was raised in the previous Q&A session. specialist clinic. So once the patient gets to the GI or hepatology care pathway, then basically we can either use liver stiffness measurement or other tests to identify patients. But another thing I wanted to highlight is still there is a place for liver biopsy in patients who still fall into the gray category even after you do your second line tests. But of course, again, another important thing is sometimes you are not really sure whether this patient actually has MASLD or another etiology which is complicating MASLD, and in that case, again, liver biopsy would be useful. So a liver biopsy still is useful, but we try to minimize the use of that, and but still you can use that to identify your further investigate your patients. Now, another question that a lot of people ask is whether FIB4 has been validated in the South Asian community. I mean, because this is a universally used test. So generally at the moment, it looks like it's acceptable, because as I mentioned earlier, most of these tests have been validated against the gold standard, which is still the liver biopsy. But we don't have enough data because we try not to biopsy our patients now. We try to avoid biopsy. We don't have a lot of data to sort of revalidate the FIB4 in different communities, but the limited available data suggests that the FIB4 is effective even in a South Asian community. So finally, when you are using the FibroScan, of course, you have to think about the limitations. And mainly thing is, so when you're integrating it to your patient care, operator and technical limitations, of course, patient characteristics, all these have been dealt with in the previous lectures. And of course, another thing I wanted to highlight was that, again, even the FibroScan is not something you use to accurately say which degree of fibrosis this patient has. It's especially in the gray zone, in F2-3 range, it's not good at distinguishing between F2 and F3. So it just says there's a high risk. So you have to do something about this. So if you want to distinguish between the fibrosis stages, you will have to do a biopsy, but that really is not necessary because you're dealing with the risk and prevention of future cirrhosis. And of course, this access and resource constraints, as I mentioned earlier, at the moment we only have two up-to-date FibroScan machines in the country, in the private sector. And there is older FibroScan machine of a previous model in the government sector. But again, FibroScan, it's a trade name, and it's actually the actual technology, as Prof. Nirala mentioned, is VCT, or vibration controlled transient elastography. So one company basically has the monopoly, and they sell the machines at an exorbitant price. It's very expensive, extremely expensive. And you have to send the machine every year for recalibration with the same company. So it's a good business model. And because the initial investment is so large, our FibroScans are very expensive, because the people who actually buy the FibroScan have to cover the cost. So in the future, I suppose the only way to sort of reduce this would be to maybe try and get more FibroScans, because India, they are doing, because they are buying so many FibroScans, they are getting at a discounted rate. And of course, now there are other machines that utilize the same technology, which are at the moment are extremely cheap compared to FibroScan, but still needs a bit more validation to show that it's actually equivalent to the FibroScan. So still access, even if we know the clinical care pathway, access to it might be different. So as I think this has been dealt with in the previous lecture. So we have newer non-invasive tests which may replace FIB4 in the future as the first line, but in our sort of setting, in our resource limited setting, these are unlikely to be cost effective, because there are so many different other variables that need to be included in these calculations. So still, I think practically FIB4 will be our first go-to non-invasive tests. So key messages: target the right patients first to make sure that your test performs well. and use simpler tests first to guide your referral. Use the FIB4. And always try to integrate the fibroscan into a defined care pathway, because that one thing is cost effective, other thing is it helps the fibroscan to perform better. And always recognize the limitations when you're using NIT and avoid inappropriate use. Thank you.
Thank you, sir, for that insightful presentation. To present a token of appreciation to the speaker, may I invite Dr. Tharanga Lianarachi, the Secretary of Sri Lanka Society of Gastroenterology, together with Dr. Udita Dasanayaka to the stage. We now move on to the next lecture. The session titled Tailoring Treatment Using Fibrosis Data to Manage MASLD will be delivered by Vidya Jyoti Professor Arjuna P. De Silva, Senior Professor in Medicine, Department of Medicine, Faculty of Medicine, University of California. May I invite Professor Arjuna P. De Silva to the stage.
Good afternoon. Morning. First of all, I'd like to thank the President, Dr. Manilkar, and Dr. Vanti for inviting us to do this. And I would like to thank all the speakers, because with very short notice, I don't think the Gastro Society has done so many lectures on a particular topic like this. So I hope it's recorded and used for the students and registrars. So I like to say that Dr. Manilkar and I were interns together, because then people assume that we're the same age or something. So this is the tailoring treatment. So I'll start off with the first case. I couldn't find one with just below 12, because otherwise the audience may be a little confused. So let's assume this is just below 11.9. So this is obese, 25-year-old obese male diabetic with MASLD, who underwent a fibroscan, and that's his report. So how would you treat him? A very practical problem. The second case is a 45-year-old patient with type 2 diabetes, again referred for a fibroscan. So he's continuous attenuation parameter, or CAP, is the amount of fat in the liver. So the fibroscan measures two parameters. Unlike the ultrasound shows everything together, this measures the fat in the liver separately, which is in blue, the CAP, and the liver damage or fibrosis, which is the key, in red, which is called LSM. So this is 25. So what is the management? So my task has been easy, because all the previous Professor Nirial also has shown this into a nice slides. So higher the fibrosis, there's an exponential increase in mortality. So if 3 and 4 drives the liver related outcomes, and it's mainly due to cardiovascular disease. So the graph shows after F3, the mortality rises. So that's why everyone was talking about fibrosis, and we are not talking about the fat in the liver so much, because it's not that important, though pathologically it may be. So this is a picture I think I this is not AI generated. It is had to use a lot of thought, put this in. A lot of guidelines have been put together. So this sort of explains everything. The Metavia score is there, and this is the Bavino 7 classification, which is classification of fibrosis, and we'll talk about it, how it affects portal hypertension. So the 8 cutoff point is very important to remember, and some guidelines talk about 12, but this Bavino 7 is a rule of 5, which is easier to remember. I think the older you get, it's easier to remember simple numbers. So 5, 10, 15, 20, 25 is easier to remember, but somewhere in there you have to remember 8. So that is important. And when advanced fibrosis happens, there is something called cackle. I will not comment much because I have fallen into trouble trying to crack jokes. So I'll keep this very professional. So that's there, and then you get how you can. This slide also shows how treatment gets integrated. We will come back to this later. So go to the next slide. So FibroScan, technically it is vibration control transient elastography is the method. So the other speakers have touched on, there are various other methods also. I think Dr. Udita gave a very passionate thing about the lack of FibroScan. That's a good point. So 1.3 again with the age. So 8 is referred to a specialist pathway, and 15 is the thing of cackle, which is compensated advanced chronic liver disease, which was not the same, but is compensated cirrhosis. So if there is a low risk, we have talked about that, it's lifestyle only, but lifestyle is very, very important because we're talking about now treatment. F2, F3, resmetirom and GLP agonist. For many, many years, there was no treatment other than lifestyle modifications. And finally, in 2024, FDA finally gave approval. I can remember Professor Madhunin was very happy about that because it was just announced. So then again, last year, when the second drug got approval, and F4 management of cirrhosis is different, not in the scope of our discussion. So lifestyle again, doctors are famous for talking about lifestyle but not following it. I think what we have been pushing. I have been telling faculty, of course, we now follow that, to eat at least fruits and not have short eats for our breaks. Right? I think if we can follow that, that's important because as doctors, we have to set an example. If we eat cake and this thing, short eats, then others will not follow that. So definitely you have to think on those lines. So weight loss is amazing. Still, it's the most effective treatment for fibrosis reversal, despite all these expensive drugs. So 3 to 5% of your weight you lose, the fatty liver gets removed. 7 to 10% MASH reversal or the inflammation. More than 10% you're reversing fibrosis. So that's amazing. And there are so many diets. Mediterranean diet is there. But I'm sure if there is enough studies on our traditional diets, not our traditional New Year food, because our traditional New Year food is about 8. That's why our president is so happy, because New Year comes, there are so many diabetics created. So then stop alcohol. we as doctors, I think we have to give that message because there is no safe limit to alcohol. So the message should be that to stop alcohol completely. Whether it's practical or not, it's a different matter, but the message should go. So this is resmetirom is the first FDA-approved drug to treat fatty liver disease or MASLD. It's an oral specific thyroid hormone receptor beta selective agonist. So 80 to 100 milligrams, 80 milligrams is as effective as 100. So the trial was Maestro NASH trial. It was the first, so it's in F2 to F3 patients, only that group only. The trial is ongoing. So F4 also it may work, but since we are following evidence, the evidence is not out as yet. So it's only F2, F3. So combining with obviously diet and metabolic optimization. So you monitor the lipids and LFT. Current regulations avoiding cirrhosis, but there are trials ongoing in F4 fibrosis as well. So this drug is available in Sri Lanka. But when you talk about drugs, always you have to tell the patient that it's lifestyle measures first. So GLP-1 agonists are used for everything. I'm sure I know personally a lot of doctors who are on that as well. So it's a very popular and very good drug with evidence as well. So this is the second drug to get FDA approval, the ESSENCE trial. Semaglutide is the drug that has worked in the trial, and semaglutide is in two forms. One, this is the dose of 2.4 dose, 72 weeks. Again, this trial is ongoing. So 62.9% achieved resolution of steatohepatitis. So just to explain a few things here, the FDA insists on biopsy before and biopsy after. Otherwise, they won't approve a trial. So all these trials have biopsy-proven effects. But I don't know how the ethics committees get permission for that, because our ethics committees will never give approval to do two biopsies. I don't know, one biopsy when they will allow, but two biopsies will never be allowed. So 36. This is even in a placebo trial. So it is a placebo-controlled trial. So even if you are getting a placebo, you will get two biopsies. So 36% showed reduction in liver fibrosis at least one stage without worsening of NASH or MASH. These are the FDA guidelines. So you can't worsen as well. And there is significant reduction in body weight, so about 10.5% with semaglutide. So safety profile was the same as in other trials of semaglutide. So this is a slide showing the differences between semaglutide and resmetirom, that is the two trials. You can see that semaglutide is actually more effective in reducing MASH or the necroin, the inflammation. And maybe in the future, you can combine both and see, because one is more effective in fibrosis reduction. So here, the differences are there. So resmetirom, mainly fibrosis and fat reduction, GLP-1 weight loss, and MASH resolution. It does reduce fibrosis as well. So then there are other drugs which are not FDA approved but are used. So like pioglitazone is an insulin sensitizer. There is some evidence that it does help, though it's not a FDA approved drug. Dapagliflozin also, and the same class can also be used to treat. Then high-dose vitamin E or the PIVENS trial, these patients were non-diabetic. So now we have discussed that one of the main target group is diabetic. So if this trial was done, again, these are all biopsy proven trials. So this trial was done, the benefit was shown mainly in non-diabetic patients. And the dose was 400 BD. Then the Flint trial, which showed about obeticholic acid, again, this did show response of reduction in fibrosis with non-worsening of and reduction of MASH. However, the FDA did not give approval, and there was a lot of side effects, and including severe intractable pruritus. So we have all used this, but now with 2 FDA-approved drugs, the reason to use this is not there at all. So definitely you have to go with the ones that are approved. So clinically significant, just to touch on this as well, because we know that if you have MASLD and it goes to MASH and then advanced fibrosis, cirrhosis, and hepatocellular carcinoma ultimately. So clinically significant portal hypertension, you can complicate this with bringing in the platelet count as well. But just to make it simple, if the liver stiffness measurement is more than 25, most likely this patient has clinically significant portal hypertension. If you see reports like that, then it will help you to understand that. So there is also in this new machine, you can measure the splenic stiffness, which is called SSME, splenic stiffness measurement. So you use the same probe, but you have an M probe to locate the spleen in the new FibroScan machines. So that also, if it's more than 50, it will signify there is clinically significant portal hypertension. So what that means is, most likely these patients have varices. So you don't have to do you don't have to do an endoscopy to confirm they have varices. And you can start them on carvedilol, which is the evidence-based drug, which is better than propranolol, to prevent decompensation and bleeding. So again, carvedilol in tackled, this is how it detects by increasing reducing the portal flow and portal pressure. And it is both the beta 1, beta 2, and alpha blocker. So it has many methods of action. So if there is no contraindication, you can start that straight away. So again, that's how it's advancing, and how the fibrosis score will help you to decide on treatment. So, so what about the future of MASLD therapy? Combination therapy is the next logical thing, and as we discussed, you can combine resmetirom, possibility of combined resmetirom and a GP1 inhibitor. The cost will be very high, but that is one approach you can do. And earlier intervention strategies are important, definitely. You need, because when the FIB4 goes up already, that means the platelet count is coming, already the liver damage has occurred. So that may not be the ideal thing. Then lanifibranor, which is a pan-peroxidase proliferation receptor agonist, is a new drug which is undergoing clinical trials as treatment. So that is another possible drug we can use. in the future. So that'll be definitely, because that's how it happens in medicine. When the difficulty is to get one drug approved. Once one drug comes in, then you get a whole gamut of drugs coming in to treat the thing. But we must not forget from lifestyle measures, which is the easiest, cheapest method. And today is World Health Day. So I think liver health is very, very important as well. So to summarize, you must treat fibrosis, not just fat, stratify the risk, and personalize therapy as possible. The right patient, right stage, and right drug. So for the first patient, he was obese, diabetic, probably semaglutide, if the cost is not an issue, would be the ideal. The second patient is already in advanced liver disease or CACR. So you have to start that patient on carvedilol if there are no contraindications. So just before I stop, this is the last slide to summarize the talk. What is FDA approved and what is not FDA approved. So about 10 years ago, or even more than that, I think President Irial was with us. We were at the DDW in the US, and they were just talking about fibroscan. So we were like looking up and thinking about this, and then someone in the lecturer asked how many people have fibroscans, and about 5 or 6 only in that room had fibroscans at that point. So then one professor, one of the people in the audience asked the speaker, what would you do if you don't have a fibroscan? So he said, the first thing I would do is examine the patient's liver. So please don't forget clinical things, because we teach our medical students that if you can't feel the right lobe and you can feel the left lobe, that is in the epigastrium, 75% chance that patient has cirrhosis clinically. So still, clinical things are important. Sometimes if you don't palpate the liver properly, you will miss that until fibroscan comes, and that we know how difficult that is. And sometimes the ultrasounds also miss those. So clinicians, please do that. Thank you. We'll stop there.
Thank you, sir, for that excellent lecture. To present a token of appreciation to the speaker, may I invite Dr. Manelka Sunatilaka, President of Sri Lanka Medical Association, together with Professor Arjuna De Silva to the stage. Thank you, sir. We will now have another questions and answer session. Participants in the auditorium may raise their questions directly, while our Zoom participants are encouraged to submit questions via the chat. May I kindly invite the respective speakers to the table to proceed with the question and answer sessions.
I'm sure you have a lot of questions, so please.
Hello, sir. I'm one of the SRs in endocrinology. I was wondering, we do get a lot of patients in the cohort, actually daily expanding cohort of less than 35 years with diabetes, pre-diabetes, obesity, and metabolic syndrome. Now, as the screening test is not validated in them, I was just wondering, in your setting, what would you advise us to do with regard to a screening test, or are we to go straight away with the fibroscan? Anything that you can advise us on that?
So unfortunately, the FIB4 is only validated above 35. So if you are to stick to guidelines, you can't apply the FIB4 to your younger diabetic patients. And there are multiple studies pointing that diabetes will have higher fibrosis than non-diabetics. So even your younger type 2 patients, probably in an ideal setting, all of them should get one fibroscan at diagnosis and follow-up. So the ideal is to do the fibroscan in the younger diabetic patients. Even the American Diabetic Association is now recommending that we do not do the FIB4 for the diabetic patients, and they straight away recommend even for the older diabetic patients to go for a FIB4. In our setting, the practicalities, we have only 2 machines which are calibrated. Both are in the private sector. That's the problem.
I think National Hospital should ask for a fibroscan.
Obviously, yes. Yeah, absolutely. I think all national hospitals should have at least one fibroscan, and that should be,
cost effective in the long run. Because we are establishing liver transplant units versus catching them early.
Sir, we have one question from the Zoom participant. How does the fibroscan change the patient's management? Is it worth by extending that much for the fibroscan?
Need that.
You want to ask?
I'll comment after. Okay. Where you gave a very passionate.
I mean, you have to take these things in context. I mean, if you mean, so the average cost is between 22 to 28,000 for a fibroscan. So I think if you take, compare that with, high fat, high protein lunch that people go out and have to celebrate things, doing a fibroscan once, I think is definitely not a excessive cost. It's not an exorbitant expenditure, and it's something that will change basically it will change the trajectory of patients with fatty liver, prevent getting cirrhosis, which will lead to much higher costs. As I think the study that was highlighted by Eranga, Prof. Niriyal and Raghav group study on the potential costs this will have on our economy. So I think in the wider scope of things, if you look at things, broadly, I think that's not a significant cost. But still, it can be made more affordable, yes. But people who really need it, I think that's worth the cost.
Yeah, just to add a few things there now. Vibration controlled elastography, fibroscan, we insist on that because that is the most recognized method, and we like to publish, so we need that definitely. And definitely where there is a gastroenterologist, I think all hospitals should have fibroscan. But for other hospitals, shear wave elastography may be enough because there are enough ultrasound machines. So if you do shear wave, that is better than nothing. So that may be a solution for the moment, because the radiologists do that, all general hospitals and can definitely do that. And the reason is we have I think all the speakers showed that your treatment will be, and your mortality is based on fibrosis. So if you value your life, I think it's worth doing that. But practically, the issues will be not having fibroscans in the state sector. But till that is overcome, actually, though it's not validated as well, it will be definitely better than not doing it.
Are there any values for the elastography which we didn't discuss much? Or the shear wave elastography, do they give a grading or how do we?
Yeah, the problem of shear wave is that different studies give different cutoffs. That's why that has not been accepted in mainstream, whereas the FibroScan values are quite well defined and very well validated. So that's an advantage of FibroScan, and most of the large scale studies have used FibroScan. And to answer that question a little bit more, there have been enough sort of cost-effective studies to say that doing at least one FibroScan in these high-risk groups that we have talked about is cost-effective. Because if you exclude advanced fibrosis, you can refer these patients back to the primary care and not overcrowding the tertiary hospitals, the secondary tertiary centers. And if you catch patients with some degree of advanced fibrosis, sort of like F3, we can prevent them going into cirrhosis. If we catch them at F4, we can prevent them from going to decompensation, because we manage patients with decompensated cirrhosis. It's a very, very, very costly disease. So we want to prevent these patients, catch them early at an appropriate stage. So it's cost effective.
I think one episode of hematemesis would will be, 4 or 5 fibroscans will be, the cost will be gone. No? So in terms of very interesting, the medication, Arjuna, resmetirom, I was just thinking with the SRs also, the thyroid TSH receptor, have you all got, do you know where in the liver the receptor is, how it is acting? Have you, the physiology I didn't understand.
No,
much,
it is a thyromimetic. So it is a TSH agonist that acts
beta receptor
agonist, which acts within the liver. So in MASLD, there are basic sciences studies that tell us that there is a intrahepatic hypothyroidism. So we are actually targeting that. So generally in thyroid disease, resmetirom is not contraindicated, but you have to be a little bit careful than those who don't have thyroid disease. There is no problem in resmetirom, but in patients who have thyroid disease, at least a baseline thyroid function and a 6-month on resmetirom is recommended.
And you have to control the thyroid. It's not a contraindication, but they have to be properly controlled.
Yeah, they should be euthyroid when you start the resmetirom.
Somebody who is subclinical hypothyroidism is also very common. TSH of 6, 5, all that with TPO antibodies positive.
Yeah.
So this might push them to become
that kind of patient. You have to be a little bit more careful. Yes.
In fact, we were young men. So we are asking for we cannot eat. So how could you advise, even though it is a clear not approved, how do you give how and
so if we go by the trial, so again I said Luisa, it's worked in non-diabetic patients and high dose, that is 400 twice as 800 milligrams a day for 2 years. So more than 2 years, no one advises continuous vitamin E. So if you, again, actually, that is our culture that we want some medicine. I understand the issue we was sometimes before we like this we were using, but ideally would be to explain to the patient that weight loss is, if you have 10% weight loss, that doesn't cost you anything to do, but is much more cost effective than giving high dose vitamin E, and there is a risk of giving continuously as well. So they don't advise for more than 2 years continuously, high dose, and that it worked only in non-diabetics, where your main catchment group is diabetic. So that's the issue. So within those guidelines, if you want to use it, then you can probably.
The one more addition, I think we should say, don't use vitamin D. Simple answer, no. Because vitamin E never reached the FDA trial thresholds. It did not reverse fibrosis. Never. It just reduces the steatohepatitis. And problem with high dose vitamin E that there is increased risk of hemorrhagic stroke in all age groups. There is increased risk of prostate cancer in the older patients. And it's teratogenic. If you are, young, female, obese, fatty liver asking for vitamin E, they have to be on contraception. It doesn't work. Don't give vitamin E. No vitamin E.
Okay, I think we have 10 to over the past years, we have been giving because of that trial. So we should
If I may just at one point, giving something actually gives us false sense of protection, which is the danger. Some patients will say, I was given vitamin E, but by not giving something and explaining that only if your weight reduces will you be safe, we are empowering and sharing the responsibility for the patient to lose weight. I mean, doing FibroScan is a good point, but if the patient hasn't achieved a BMI of 23, FibroScan, it's not going to help. So what we need is to empower and explain to patient to stick to the diabetic diet, lose the weight, achieve BMI 23, and that is the therapy. Because even if you do FibroScan, a lot of patients might not be able to afford in our sector resmetirom or semaglutide in the government sector. So what we need to really focus is to make sure their weight, diabetic compliance diets are really achieved. Taking vitamin E actually gives a false sense of security that we are getting something. Once they don't have that, they have to face up to the fact that I have to lose weight, otherwise there is no answer for this other than losing my weight. So we have to focus on that and achieve the weight.
Yeah, but I have noticed we also have given, after that trial, so like ALT and AST of 55 to 60 tends to come down to 30. So that is a false sense of security.
That is because vitamin E temporary, if you give, the steatohepatitis comes down.
But it doesn't
do anything for the fibrosis.
No prognosis, no benefit in the prognosis. But if the hepatitis comes down,
that's a false reassurance.
Another process doesn't get reversed. Similarly with this ursodeoxycholic acid.
I think vitamin E, pioglitazone, and obeticholic acid, they are out.
Pioglitazone, the ADA and the ESD now they have said with the people with steatohepatitis and diabetes recommended.
No, you can use pioglitazone for the treatment of diabetes if there is steatohepatitis. So that can be an agent that can be used, but it's not going to reverse the liver outcomes. That's the problem.
Have you all heard of saroglitazone? It's an Indian product. They are, in Indian meetings, they have, it's a dual PPAR, alpha and gamma, like the the new drug you were telling, PAN, PPAR. So it's a dual blocker, so which they are using. So it's similar.
It is actually the Indian regulatory authority has actually approved it. But I don't use it because there is no. It's based on one very small study, just one very small study. I don't think it's we can generalize the finding of that study to treat our patients.
It's a big lobby because of the Indian thing to put it into our thing, because we were following only the BNF now. But as India said, there is no evidence for that. But in Indian guidelines, they are put it in.
Special.
It's very unlikely like fatty liver, because that means the abdominal activity is there because things have advanced, all these tests are very expensive for women. So it's kind of observing the abdomen, going back to the basic, and the palpitation.
An abdomen with a visible rib cage we see only in K-pop now. we hardly ever see that kind of abdomen in our clinical practice because our patients have, round big tummies.
I think best thing is to remove the shirts here and see whether, whether that's no, but I was talking about the clinical thing was to to diagnose cirrhosis, but definitely the point is taken that clinical. That's what I was trying to emphasize because there is lean NAFLD as well, so you can be lean and you can still have NAFLD, and that may be more aggressive also. So, going only on the weight and appearance may be misleading. So, but never forget what I was trying to emphasize is never forget the importance of clinical, even with AI, whatever said and done. We have what we tell our medical students is we have had x-rays for hundreds of years, but we still examine the chest. And we have CETs, but we still examine the chest. So clinical skills are always important. But I think just observing the patient may be misleading. So we'll have to do some form of investigation, ideally fibroscan or at least ultrasound scan.
Is the right hypochondrial pain any sort of correlation clinically, like the stretching of the capsule or glycerol,
It doesn't have any direct link to the severity of liver disease, but the explanation is that when you have steatosis, the liver is enlarged and the capsule is stretched. So that capsule is usually sort of abutting the rib cage. That's why they get the discomfort. This just says that the patient is likely to have a larger liver because of the fat. So
most of the time, when you want to, now of course we have to uniformly screen. Those days when they say that we do the scan, it's grade 2 fatty liver most of the time.
That's a very common sort of early symptom of fatty liver, the right upper quadrant discomfort because of the liver enlargement and capsule irritation.
People take a lot of supplements that are not regulated. And do you know of any that are toxic to the liver? I think this might be more of a problem in other countries than in.
So it is a problem in our country as well. There are many unproven traditional medicines that are being promoted on social media. That is thought to be helpful in reversing the fat and reversing the liver disease, even reversing cirrhosis. There is no proven data with regards to some of these herbal medicines, especially hemboitia and things. And what we see is that we see the extreme other side. We see severe drug-induced liver injury related to these various liver protective supplements. And we see severe liver failure where we have to put to the ICU, do plasma exchange and, work very hard to save these patients. And sometimes we lose these patients also. So we do not recommend any of those supplements that are unproven, unregulated for improving steatohepatitis, MASLD or cirrhosis. Mananjan, you want to add anything?
Basically, we can be about it also in some of these patients can have compensated cirrhosis, undiagnosed. So in patient who has compensated cirrhosis, if they take a herbal product, there's a risk of acute or chronic liver failure, which is a very serious thing with poor prognosis. So we really are fully against any herbal products, anything, supplements. Hepatologists will be sort of quite allergic from a professional point of view, I think.
So supplements are my pet hate, and I have been fighting against supplements for a long time on a different platform. So especially people online here, so there may be gym people. So how gyms operate is not on, they make a profit not on the membership. The membership is very small. They operate on selling you supplements. So we have done studies showing that when you take whey protein, your cholesterol goes up. So because it has a high concentration of cholesterol, so That is just one part. If you talk about whey protein, so all the other gym supplements can cause. There's so much evidence that it causes liver damage and various other things. So definitely avoid. Go to a nutritionist and follow him because we found that even in our national cricket team, they were taking supplements without telling us. And when you do their diet, you find that they are on too much protein because of the supplements. So your first step is to have a nutritionist analyze your diet and then see what you're deficient in and then take that.
Are there any place for the simple integrated procedure like background fixation, undernutration, urinary resurface, management of MASH?
So there are multiple endobariatric and bariatric studies that have looked at pre-treatment and post-treatment. And definitely the weight loss helps. However you achieve it, the weight loss helps. So at the moment, there are no guidelines that are recommending MASH as the primary indication for endobariatric therapy or bariatric therapy. But in total, in whole context of the patient, if MASLD is one component, yes. So the guidelines go by the BMI and the cardiometabolic risk factors, and one risk factor can be MASLD. MASLD in isolation, no. So the weight loss recommendations are for obese patients, overweight patients, BMI more than 23, 5 to 7% will get rid of the fat. 7 to 10% will get rid of the inflammation, and more than 10% can reverse some of the fibrosis. Remember that 3 to 5% doesn't do anything to your patient with regards to the steatohepatitis or the cardiometabolic risk factors. It won't improve diabetes. So just mild weight loss is not enough. We really need to go for adequate weight loss. Most of our patients will benefit from 7 to 10%. If they can achieve 10%, okay. For the lean group, it's half. So that's 3 to 5%. So 7 to 10% becomes 3 to 5% in your lean patients who are less than 23 BMI. However you achieve it, doesn't matter. The recommendation is regular physical exercise outside your normal daily activities. You should get recreational time to do special, regular, moderate physical exercise, 200 minutes for a week. That comes to about 40 minutes 5 times a week. And the diet is a sugar-free, low-fat, hypocaloric diet. Although we talk about the Mediterranean diet, it's prohibitively expensive and we can't, we can't afford a Mediterranean diet. But the basic is that it's a hypocaloric diet. It should maintain minus 500 to 600 calories of your requirement. That's the hypocaloric diet. I think best to involve a nutrition specialist in your management of your patients, because if you just give this summary of diet, exercise and send them off 6 months, they come back with the same weight, and most of the time they are put on weight also. So I routinely now get use of a clinical nutritionist, or sometimes we have now sports medicine specialists also for exercise. The difficult patient should be referred, and this should be a multidisciplinary team management, because we are not only managing the liver disease. If you see the mortality in these patients, the number one killer is the cardiovascular, number two is gender and age-specific cancers, and number three is liver. So you have to manage the cardiovascular risks, and that is through weight loss.
And on the same aspect, the ESSENCE trial, I noticed that the study subjects more than 10% weight loss, and the control group was 2%. Now that improvement was over and above the weight loss due to the weight loss achievement
Yes.
on semaglutide, or have they done the
No,
math?
they had no. It was not only on the weight loss. Above.
No, the improvement that was seen on ESSENCE with semaglutide was independent of weight loss. They did correct it for the weight loss.
Can do exercise. Good that you brought that. So now we have sports medicine consultants. So exercise prescription, there are no.
Just like diet, nutrition, exercise is a prescription. You have to prescribe the patient the correct exercise. Every exercise won't be appropriate for each patient. Patients may have comorbidities that may not allow them to do a certain type of exercise, but another exercise would be more useful. So exercise is a prescription. Diet is also a prescription.
And one more question.
Thank you very much for sharing your answers, sir. So my question is with regard to screening tools available for invasive screening tools available for screening MASLD, such as material index, index like things. So how you advise on combining these screening tools along with that screening for insulin resistance, such as trimethyl glucose like these when you're using these primary settings, especially post delivery, that ultrasonography is also not really available. Such can test that how you can advise on using those screening tools to screen the patients basically.
Who wants to answer? You want? Yeah.
But if you, with regards to the question, of course, if you take the definition of MASLD, the screening for metabolic syndrome is already included in the screening. But I get your question in a practical setting. I suppose if you detect for some reason steatosis or suspicion of fatty liver in a patient, then that should trigger you to sort of investigate further to see whether the patient has any other components of metabolic syndrome, which has to be additionally managed. And just to touch on the ultrasonography, ultrasonography again is now in the guidelines. It's actually not essential. It's not recommended as a first-line tool for screening for at-risk steatosis, because the problem there is, as was mentioned in the lectures, the definition of steatosis or fatty liver is more than 5% of hepatocytes having fatty liver, but or having fat. But ultrasound actually catches it at around 20%. So there is a large gray area that will not get detected. So ultrasound, because it requires a specialist involvement. Ultrasound is not generally recommended as community screening first line. So first line would be a FIB4. But yes, I think we need to do screening for other metabolic risk factors if a patient is detected to have steatosis, if we have ruled out other causes.
So your grade 1 fatty liver will be 20% fat.
20%.
So I think our scans uniformly, I mean, I don't know, in our patient population, uniformly there is a grade 1.
I think there is no need for this grading. I think the radiologists are using it. Those are criteria to diagnose fatty liver. Grade 1 and 2 and 3 are actually 1 criteria, 2 criteria, 3 criteria. Increased echogenicity, there is blunting of the portal vessels, and there is the sort of blurring of the diaphragm. So those are the 3 criteria. So a person who has grade 3 has all 3 criteria. So it is irrelevant if your ultrasound scan says fatty liver, that's it. The patient has at least 20 to 30% of fat in the liver, and that by definition is steatotic liver disease.
The patient's weight will determine the progression, I think, rather than serial ultrasounds. But have they lost weight, then it's improving. If they haven't lost weight, then it's
we see a cohort of this thin fat, what he was talking. The thin fat in Indian or the YY hypothesis, like the insulin resistance syndromes. I think there's a lot to do with, in diabetes, we have the twin cycle theory, where the fat in the pancreas is also big. And there are studies to say reversal of diabetes can be achieved by reducing the fat in the liver and the pancreas. They are studying the pancreas with MR spectroscopy, where they have shown how the fat disappears by 10% weight loss. You know, the studies, direct study has shown clearly that everything reverses. So I think this to do with the insulin, intrahepatic insulin resistance also may be a factor which we have to study, and the thyroid hypothyroidism, which is new. It's an interesting area for us to study.
One more comment, I think probably the last comment. So this thin is also misleading. Although by BMI criteria, they are thin. Their BMI is less than 23. But if you check the waist is above the sort of cutoff for the Asians. For males, it's more than 90. Females, it's more than 80. That is because of visceral fat.
And we go by the body fat composition and the visceral fat.
That's it.
I think
we will now conclude the question and answer session. Thank you, sirs, for your contribution and participants for your active participation.
One more.
We now come to the final academic segment of today's program, the interactive case discussion titled Empowering Decision Making, Putting It All Together, will be led by Dr. Tharanga Liyanarachi, Consultant Gastroenterologist, DGH Kampaha. May I invite Dr. Tharanga Liyanarachi to the stage?
Thank you, Professor Arjuna De Silva and Dr. Manilka Sumartilaka, President SLMA, for giving me this opportunity. We have come to the last lecture in today's program, Empowering Decision Making by Putting It All Together. I will be presenting some cases to you. So I hope we will have an interactive session. These are my objectives. Moving on to case number 1. A 38-year-old male is referred after an incidental finding of fatty liver on ultrasound scan during a routine health check. His BMI 22.4. There's no history of alcohol use. There's no known diabetes, hypertension, or dyslipidemia, and he is asymptomatic. Initial lab report says ALT of 32, AST 28, normal platelet count, fasting glucose 102, HbA1c 5.8, albumin 3.9. So what is your impression? He's a normal weight patient, or rather a person with a normal ALT. Do you think this is low risk, or do you want to do anything more? What would you want to know about this person? So we have gone ahead and calculate the FIB4, which is 0.9, and NAFL score minus 1.6. So it shows a no risk, or rather low risk. So would you stop here and discharge the patient, or reassure and advise him about lifestyle advices for his pre-diabetes thing? Or do you want further risk assessment in this person?
so now audience can be interactive, otherwise you'll be feeling sleepy, so you can just jump out. So I would actually reassure and give lifestyle advice, but since you are presenting here,
Yeah, I think we have actually, we thought of doing further evaluation to look into his metabolic risk factors and his waist circumference. This should be 95. Let's take it as 95. And triglycerides 210, HDL 35, and he has a family history of type 2 diabetes. Would you still reassure and advise on lifestyle advice, or would you want to do something else? So when we look deeper, so it shows this person has central obesity and elevated triglycerides and low HDL. So he's a metabolically obese, normal weight person. So the diagnosis here would be a lean MASLD. So we would go ahead with a fibroscan, even with a low FIB4. When we check the fibroscan, his liver stiffness 7.8, just less than 8, but very close, and cap is 273. Now we have a low FIB4 and a borderline fibroscan. So to resolve this, go back and think, now he's a person less than 40 years of age. So FIB4 is less reliable. And lean MASLD is under-recognized, but he has metabolic risks. So our decision was to closely follow him up. We don't have MRE, otherwise it would have been an option. So the management would be to advise on lifestyle, 3 to 5% of weight reduction, even if lean, reduce visceral fat, aerobic and resistant exercise, and treat the dyslipidemia and monitor for diabetes progression, and follow-up strategy, fibroscan, every 2 to 3 years, but if his metabolic risk factors are not improving, maybe earlier than that. So lean MASLD is actually diagnosed in individuals who fulfill other MASLD diagnostic criteria, but BMI of less than 25 in Caucasians and 23 in Asians. It is estimated to account for approximately 5 to 13% of worldwide population, and it's notably more prevalent in Asia. They have 1.6-fold higher risk of all-cause mortality compared to non-lean MASLD individuals. This is again a comparison. So, as I said earlier, it is more common in Asian populations, and they have strongly genetic predisposition, and it is also associated with high carbohydrate, low fiber diet, refined starch and rice, which is common in Asia. And it's usually underdiagnosed, but it has a higher risk of fibrosis progression. When you compare Asia and West, there is more genetic polymorphism and carbohydrate intake and increased visceral fat in lean MASLD. In the West, they will have more non-lean MASLD patients with low genetic polymorphisms and increased fat intake. Moving on to case 2. A 54-year-old male with a 10-year history of type 2 diabetes mellitus and hypertension was referred for evaluation of incidental fatty liver detected on ultrasound. He has a high BMI, 26.8, waist circumference of 98, alcohol intake minimal, 10 grams a week, medications, metformin, glycoside, atorvastatin, and losartan. These are the initial lab investigations. ALT 28, AST 26, normal platelets, HbA1c 8.2, lipid profile, elevated triglycerides, and low HDL. What would you do next? Yeah, so his FIB4 is 1.6, NFS minus 0.32. What else would you want in this patient now? Transient elastography, 9.8 kilopascals, and CAP score 320. What do you think the diagnosis is here? You're most welcome to answer, postgraduate trainees, registrars, SRs. So the diagnosis here is MASLD with significant fibrosis in a patient with normal ALT. So the management would be target of 7 to 10% weight loss, Mediterranean style diet, as Sir said, hypocaloric, rich in omega-3, regular physical activity, at least 150 minutes of aerobic and resistant training per week. And metabolic optimization is essential here because this patient has high HbA1c and high cholesterol levels despite being on drugs. So we have to look at the drug compliance and blood pressure management also. We may consider GLP receptor agonist, SGLT inhibitors, and resmetirom here. But as all were emphasizing before, lifestyle plays a key role in this patient. So in MASLD, the normal ALT does not exclude anything. It lacks the sensitivity of detecting fibrosis, and up to 30 to 50% of MASLD patients with advanced fibrosis may have normal ALT. So diabetic patients are particularly at risk of silent progression. So we have to be very careful in these patients. So being diagnosed as type 2 diabetes is one of the strongest predictors of fibrosis progression. I will show you something I came across last week. This is a 62-year-old patient with diabetes who is followed up at a local hospital clinic. He brought me these two reports. So in October 2025, he has had serum investigations. And as you can see two tick marks there. They have put a tick to the creatinine as well as ALT. And at that point, patient was not referred anywhere. Patient was given diabetic medications and usual prescription. And last week, 27th of March 2026, patient has noticed real discomfort in his abdomen and gone to a general practitioner and got a ultrasound scan which shows cirrhosis of the liver with moderate ascites. So don't lose that window of opportunity in our patients to diagnose and treat. Once they come into cirrhosis with ascites, they already have decompensated. So always think actively, even if they have normal ALT levels, always do your non-invasive testing first and then refer appropriately.
Can I stop you there because this is a very common scenario. All of us may be missing in our hundreds of patients attending, our clinics, and this sort of number won't catch our eye, even our medical officers doing the annual screening. I have seen such numbers. What do you suggest now practically? Run the FIB score, FIB4. Have you done the FIB4 for these parameters at that level? What do you think? Was there a discrepancy?
Only thing, sir, they have not done the AST. So I actually thought of doing the FIB4, but they have not done the AST, so I couldn't do it.
But if you are interested, you are most welcome to our clinic and do some, see I have data about 5,000 diabetic patients with all ALT, AST. The data is there. If you can, with Asita's team, I have tabulated. I'm just wondering whether we should run the FIB score and then see the ultrasound, whatever we have done, or whether we should do and see the correlation. Because, I know you still have a missed opportunity. This is a day-to-day busy clinic in a medical clinic or something. It will be impossible to, we have to be really have a clue which one to pick. And otherwise, imagine we have a quota of 4 ultrasound scans for a day for my clinic, right? 4. So how do we, 400 patients count? We are not going to catch them. So we need to think of something, some other parameters. And what about the gamma? I see lots of patients, only high gamma GT, no alcohol, nothing. Ladies, ALT, AST, so-called normal by looking at your values, we also say normal 32, 33, we don't bother, we don't look at them, carefully. And high gamma GT, 65, 70, isolated, no alcohol. Any correlation, or how do we FIB4 Is there a connection?
Yeah, isolated gamma GT elevation seen in a subset. Yeah, that's very important because the alkaline phosphate is also high. We should think of cholestasis and some bile duct disease. But if the alkaline phosphate is normal isolated gamma GT with an ultrasound fatty liver, that is quite compatible. There are subsets of patients who have only isolated gamma GT in MASLD. Then well described, but it's a minority, not the majority. So, Monica, in your clinics, you routinely get the AST and ALT both. This patient is missed because it was only the ALT, the AST. Now, in patients who are having sort of progressive liver fibrosis, the gap between the ALT is usually higher than the AST. The ALT has a much longer half-life. Usually, in a normal person, the ALT will be almost always more than the AST, which is a shorter half-life. If this gap is narrowing, if the ALT is coming down and AST is going up and they are almost touching. Now, this patient had in the clinic ALT of 37 and AST of 35, I would be worried because they are almost touching. That means there is some degree of fibrosis. That's a early marker of early fibrosis.
What's the normal gap you are? Because we do AST and ALT, and I don't think our MOs are also, we have trained them to look at it such, close scrutiny. We have like thousands of patients. Every year we do a endocrine screening and we do all these tests. But it's just that how we look at it, and we of course we look at when it's more than 45 or 46, because the upper limit again given in our level. What is the normal gap?
Normal gap, I would say, an ALT of 40 and AST of 20, like 2 to 1. Yeah, they are quite apart actually in a normal person. But if they are coming very close together, almost equal, I hope the postgraduates know why the AST rises when there is liver fibrosis. Let them find out.
So, moving on to case 3, a 48-year-old female was referred for evaluation of incidentally detected fatty liver. She's a patient with type 2 diabetes mellitus for 5 years and a dyslipidemia, BMI 31.2, waist circumference of 104. There's negligible intake of alcohol. She has high ALT 52, AST 38, platelets normal, HbA1c 7.8. Would you want to know the FIB4 in this patient? So FIB4 is 1.1, low risk, NAFLD score, indeterminate. So there's low probability of advanced fibrosis. Would you stop here or would you want me to show you the elastography? Yeah. So we have to do second line testing because of the metabolic risk. So transient elastography showed liver stiffness of 12.5, which is suggestive of advanced fibrosis. CAP of 310, severe steatosis. Now, FIB4 says low risk, FibroScan says advanced fibrosis. Initial scan, ultrasound scan showed only fatty liver. The discordance between serum markers and elastography is very common, 20 to 30%. Why does this happen? Because we have limitations for FIB4 as well as for FibroScan. FIB4 is age dependent. It is less sensitive in younger patients and it is influenced by platelet count and mild transaminase elevation. And it may underestimate fibrosis in diabetics. Limitations of FibroScan, which can be falsely elevated in inflammation, acute hepatitis, hepatic congestion, severe steatosis, high BMI, cholestasis, and recent MIA. It can be falsely low due to early fibrosis, technical failure, and operator inexperience. So both tools have context-specific biases. So the same thing, which in a large cohort of patients, which they have found out, the 10% of low risk by FIB4 persons actually had higher LSM values. Sometimes 2.7% had more than 12. So in conclusion, FIB4 causes both underestimation and overestimation, and misclassification is clinically significant. This is another slide showing the same thing. And if you trace the red lines here, which goes above 15 LSM score, low FIB4 as well as high FIB4, more than 1.5, both can have more than 15 kPa levels for LSM. So in our patient, her risk profile overrides the scores. She has diabetes, obesity, and dyslipidemia. So in such patients, low FIB4 does not safely exclude the disease. So what do we have to do? We have to reevaluate technical factors. So quality of the FibroScan. We have to see whether the IQR median is less than 30%, and whether we have used the larger probe, which should be used in obesity, whether we can do another non-invasive test like ELF or MRE, or whether we can consider liver biopsy if the results are going to impact the management. So in this patient, FibroScan is repeated, but it showed, even though it showed persistent high stiffness, it has come down to 11.8. Viral markers were negative, autoimmune markers negative. Liver biopsy is performed, which showed steatohepatitis with bridging fibrosis. The final diagnosis is MASH with advanced fibrosis. She was advised on lifestyle, metabolic optimization, and also resmetirom. What happens if a patient comes to you and say, I can't afford resmetirom? And there was an era where we did not have resmetirom up until very recently. What would you tell that patient? This is a real patient, actually a consultant in maybe he's 57. So in 2024 September, he had a FibroScan. There, the LSM is 8.2. And at that time, his weight was 68. His BMI was 28.3. He engaged in a thorough lifestyle modification with regards to his diet and exercise. And he managed to lose weight 14 kilos, actually within 6 months. He has lost this weight within 6 months. But he was not very keen to repeat the FibroScan until very recently. So we had to push him to get this test repeated to see that now when his BMI is 22.5, his LSM has come down to 4.2 and he has no steatosis.
He would have taken GLP-1 receptor agonist without taking.
That was also, I think, not available at that time in 2024. I don't think it was in practice. So
it's a good weight reduction.
Real good weight reduction. And currently it costs about 30,000 per patient for monthly prescription of resmetirom in Sri Lanka. So if patients can't afford, always tell them lose 10% of body weight within 6 months and engage in daily exercises and have a good diet. You will definitely lose your LSM. Moving on to case number 4, a 42-year-old male was referred for evaluation of fatty liver.
Just to interrupt, when you go back to the last slide,
yeah,
resmetirom is not indicated for this patient. It must be clear.
Yeah.
8.2.
Yeah.
No, the trials are actually, they have given a LSM value between 10 and 15. That is the margin where there is significant fibrosis. So more than 15 is advanced fibrosis. So something more than 10, less than 15, resmetirom or semaglutide is indicated. More than 15, we don't give because we don't have the evidence for tackle it yet. It will come probably later, but not now. Yeah, if there is another indication like obesity, you can give the semaglutide, no problem, but not for the NASH. As per current guideline. And PIMPO, more than overestimation is a huge problem, underestimation. The problem of PIMPO in diabetes is underestimation. So they are given false reassurance by a normal PIMPO in diabetic patients who have multiple cardiometabolic risk factors. So it's the underestimation that is the more problematic. It really overestimates.
It's a correction. You should work on a method like our, the DEXA scans. We have the Sri Lankan model.
The lecture spoke about MAP5. So there are others, better scores that are performing better than PIMPO.
And also, I don't know how clinically significant this would be, but most automated full blood count results would give a platelet count of, let's say, 150, but when you calculate it manually, it'll be more than that. So it is also something that we should be taking into account later if you are really going into deeper. So case number 4, a 42-year-old male was referred for evaluation of fatty liver detected during a routine health screening. BMI is 22.9, waist circumference 90, is mild dyslipidemic, no history of diabetes or hypertension. There's a drug history of natural herbs which has been taken for the weight loss. There's negligible intake of alcohol. ALT 34, AST 32, platelets 165, HbA1c 5.4, lipid profile mildly elevated LDL.
Okay, now we know.
Yeah, so actually before FIB4, because he's, right, so yeah, so investigations, we have excluded viral hepatitis in this patient, autoimmune markers, iron studies, and Wilson's. So in FIB4, it was 1.9, FibroScan 14.2, with a cap of 285. Now we have another clinical paradox here. He's a lean patient, no diabetes, normal, near normal ALT. I know it is 34, yet evidence of advanced fibrosis. What would you like to ask this patient?
So alcohol, concoctions, Bovitia.
Oh.
And the family.
Didn't ask about the family history, but yeah, the key was in the history. So he was taking over-the-counter herbal supplements for weight maintenance for more than 5 years. So it raised the suspicion of toxin or herb-associated steatohepatitis contributing to MASLD phenotype. So he went ahead and had a biopsy, which showed steatohepatitis with bridging fibrosis, and additionally, there were features suggestive of toxic and metabolic overlap injury. So it's actually a dual hit model where lean MASLD plus herbal and supplement-induced liver injury is shown in this patient. So the recommended strategy is to take a detailed exposure history about the herbal and toxins, an early elastography, and have a low threshold for biopsy in these patients. So as you can see, people take herbal or natural remedies for various things, for bodybuilding, for weight loss, for sexual performance, GI upset. So all these have been implicated in drug-induced liver injury. Moving on to case number 5. A 52-year-old male was referred for evaluation of fatty liver with elevated liver enzymes detected during routine screening. BMI of 29.4, waist circumference 102. He's a diabetic for 8 years with hypertension and dyslipidemia. He gives a alcohol history of occasional social drinking, 5 to 8 units weekly. Pardon me, sir, I will scale it in grams. So it is 40 to 64. 40 to 64 grams a week. His ALT is 68, AST 72, AST to ALT ratio more than 1, gamma GT 180, platelets 145, HbA1c 8.5. So in initial assessment, ultrasound scan showed the fatty liver. FIB4 is elevated, more than 2.67, 3.13. So initial working diagnosis is MASLD with advanced fibrosis. And transient elastography showed liver stiffness of 16.5 and CAP of 295. But are you really happy with this diagnosis, or you want to do more about this patient when you see elevated gamma GT and thrombocytopenia? So there are clinical red flags here. And then there is fibrosis disproportionate to the metabolic risk. So whether there's any additional liver enzyme is there in this patient, we had to go back and ask about the alcohol history. And then he said daily intake of 3 to 4 drinks of spirits on weekdays and 5 to 6 drinks on weekends. So it is 25 to 32 units per week. And there had been significant underreporting initially. And the final diagnosis came as MASLD, metabolic dysfunction associated liver disease with significant alcohol contribution with advanced fibrosis. Underreporting of alcohol is a common pitfall. 30 to 50% of patients underestimate their alcohol intake, possibly because of social stigma and recall bias and misunderstanding of units. And it leads to misclassification as MASLD. And there can be overestimation of LSM value if the fibroscan is done while the patient is drinking. So it should be ideally done 2 to 3 weeks of alcohol abstinence. So self-reported alcohol tools like Odyssey, Cage, it captures at least 40 to 60% of actual alcohol consumption. And so what we conclude here is underreporting is systematic and substantial in MASLD populations. So we have to use structured tools to get the alcohol history, and biomarkers like gamma GT, phosphatidylethanol can be used even though phosphatidylethanol is not available in Sri Lanka or CDT. So they improve the detection of hidden alcohol use. So in MASLD, you have to intervene both the metabolic optimization as well as the alcohol. So strong counseling is needed and referral for de-addiction support. And target is to complete abstinence. Metabolic optimization is essential in this patient with tight glycemic control, weight reduction, and lipid management. So the key points in my lecture: lean doesn't mean low risk. They may have higher fibrosis than expected and strong genetic and metabolic drivers and increased cardiovascular disease risk. Always look beyond BMI, visceral fat more than the BMI. They can be skinny outside but fat inside phenotype. ALT is misleading. It can be normal even in advanced fibrosis and MASH. FIB4 is less accurate in younger patients and early disease. Discordant non-invasive tests are common and expected. Clinical judgment overrides isolated results. Do not rely on a single test. And liver biopsy remains the choice in selected cases. And history of herbal medications and accurate alcohol quantification is essential. Let's come to the end of my lecture. So I'm happy to answer if you have any questions.
I have more questions because it's very relevant to our specialty. So I think we should ask the PGIM to send some of your trainees for 1 month with us and our trainees for 1 month to resolve this problem, to get the nitty-gritty and because I think it's going to be a huge problem if we start actually in my clinic. Huh? No, we need your trainees to come and analyze our data because our trainees are so busy. No, the thing is, my clinic now, there are about 40,000 registered patients. Right? I mean, we haven't analyzed in this detail, the FIB4, I have told them to do, but then there are so many pitfalls also, like looking at the AST, ALT and that difference and all that, it was not in our radar. So those are new things that we should get, maybe at a trainee level, we should do another sort of a lecture on the pitfalls. They know the basic stuff now. We'll arrange that for the endo trainees. Yeah, it's very good and very open our eyes to look more carefully at the reports, I think. The difference between the ALT and AST and the narrow gap and the reversal, all that. And not look at the lab, some certain labs, it gives 65, ALT and all, certain labs give 65. So you just ignore because we think that different method of testing and all that, they say 0 to 65. So especially I noticed that earlier one would have been a down south lab, that your cirrhosis, I noticed the lab. So I don't know whether it was one of my patients. And 65, then some labs give 65. Right, so, yeah.
Just one comment that I think the president has benefited the most from this. But please keep your patients, we are coming for them now.
Thank you, madam, for that informative and highly engaging session. To present a token of appreciation to the speaker, may I invite Dr. Ruanti Jayasekara, Assistant Secretary of the Sri Lanka Medical Association, together with Dr. Tharanga Liyanarachi to the stage. As we come to the end of this enriching workshop, I would like to express my sincere appreciation to all our distinguished speakers for their contribution and to all our participants both here and online. Engage. I now invite Dr. Ruanti Jayasekara, Assistant Secretary of the Sri Lanka Medical Association, to deliver the closing remarks.
As we come to the close of a very successful pre-Congress workshop on MASLD, on behalf of the Sri Lanka Medical Association, I would like to thank the Sri Lanka Society of Gastroenterology for collaborating with the SLMA for today's workshop. I would like to mention a special thanks to the list of eminent speakers today, Dr. Eranga Thalagala, Dr. Hirumi Jayasena, Dr. Mananjala Senanayaka, Professor Madhuni Niriyala, Dr. Udita Dasanayaka, Professor Arjuna De Silva, and Dr. Tharanga Liyanarachi, the faculty from the Sri Lanka Society of Gastroenterology for their excellent speeches. And a special thanks to our online and on-site participants for their interaction and their lively discussion. I'm sure we all learned a lot today. On behalf of the SLMA, I would like to thank
Our sponsors, Navaloka Hospitals PLC, Ms. Rasika for coordinating the event today, Micromega Lanka, Pharma Evo, and Emma Femi Ceylon Limited. So as we come to the end of a successful session, I would like to invite you, I would like to take this opportunity to invite you to the main congress that is happening in July this year. Then we can speak about sponsor. And also we have two or three workshops in line over the coming months, and I would like to invite you to participate in these workshops as well. Thank you.